It's a kind of torture to be here for all of us on Sunday. I'm Dr. Pooja. I am a breast surgeon at Medica. And thank you so much for being here, joining us for this academic session here on Sunday morning. We had a very nice session yesterday. I'm sure some of you would have attended it. So continuing it today. So we'll start the GI session today. One by one, I would like to call upon our chairperson, followed by the panelists. So please join me on the dais when I call upon your name. So starting the GI session, the topic would be gastrointestinal G-junction tumors. The chairperson would be Dr. Conclave Das, Senior Consultant Gastroenterology, Apollo Hospital, Kolkata. Good morning, sir. Dr. Shubrata Chatterjee, Professor Radiotherapy, Medical College, Kolkata. Good morning, sir. I would like to call upon the moderator of the session, Dr. Swapnil Patel, Associate Professor of Surgical Oncology, EMC. Good morning. Please panelists join me on stage. Dr. Suresh, Consultant Surgical Oncology, Medica Hospital, Ranchi. Dr. Raman Prem, Consultant Surgical Oncology, Jharkhand Cancer Center, Ranchi. Dr. P.K. Shetty, Director, Department of Medical Gastroenterology, Medica Super Speciality Hospital, Kolkata. Dr. Swatika Majumdar, Consultant Medical Oncology, Narayana Hospital, Bangalore. Dr. Puneet Sharma, Senior Consultant and Adjunct Professor, Nuclear Medicine, Apollo Multispeciality Hospital, Kolkata. Dr. Nilatri Bihari Patra, Dr. Professor Radiotherapy at SSKM Hospital, Kolkata. Dr. Sweet Das, Consultant Medical Oncology, Medica Oncology, Kolkata. Over to Dr. Swapnil Patel.
Before Swapnil takes over, I think the Sunday starts like that. The morning starts always like that. And most of the meetings you have every day, there are meetings for the world like anything. You try to count that possibly those people who are getting born or dying from this world is more meeting than that. It's very important. All of us sitting here will accept that. See, when we started, and in fact, I have senior people sitting here. In 1980s, we have only 5 FU, and if a person is diagnosed with cancer, is gone. A person coming to me in gastroenterology when I was doing an MBBS and even entering into MD, my thesis were in gastro. So there's in the chapters of gastroenterology, the write-up of oncology was very good. In fact, my teacher, Professor Mehta, was the godfather of gastroenterology. If a patient is diagnosed as malignancy, shifted to surgery or oncos. It was like that. So now down the line in 4 decades, we have ahead, really much ahead in our, in fact, a little bit contribution, but most contribution has come to oncology is by the radiologists, as at least people like Puneet sitting here, who is my friend, and they have really mesmerized us, giving us where we should go as a surgeon, and in fact they helped us whereas Pradito is sitting here, my brother, where we go and hit the ball before the onco people takes over. So sometimes it happens. So now it's everything now to my, you will say a little what, why here?
Okay, so something. We will start. That I think it will be a very good session and it is the need of the hour. The guest, the guest to sway your Johnson.
So, good morning everyone, and after the warm introduction by our chairpersons. So, gastroesophageal junction tumors are a grey zone in the management of GI cancers. They lie, it's a very strictly defined category of tumors. It's an anatomical definition, and there are a lot of grey areas with respect to various aspects of management, be it chemotherapy, neoadjuvant, adjuvant treatment, surgical approaches. And the evidence for most of these things is still evolving. Most of the evidence for most of these things have been extrapolated either from the treatment of esophageal cancers or from with this I'll begin. So esophagogastric cancers, they represent around 27% of overall gastric cancer cohort, and most of these esophagogastric junction tumors are adenocarcinomas by histology. Squamous cell cancers are relatively rare, and the DNA classification of the 8th edition has defined G-junction adenocarcinoma as having epicenter within 5 centimeters of the G-junction and extending into the esophagus. On the right here on the screen, you can see the famous Sievert's classification, classifying these G-junction tumors into type 1, 2, and 3, which I'm sure all of us are aware of. So what I have done is that I have kept 3 cases, and through the cases we'll go around and have a look into the various aspects of management of these G-junction tumors. So for the first case, the patient is a 37-year gentleman who presents to us with a complaint of pain in abdomen, and examination is essentially normal. He has come to us with an endoscopy report from outside, which shows growth starting from gastroesophageal junction and involving the fundus and cardia of stomach. And biopsy has already been done outside, and it has shown a poorly differentiated adenocarcinoma. So what next? Now we need to image the patient. So I would like to ask Dr. Puneet, what are your views on getting a PET scan done directly for this patient? Would you advise so?
It's ideally preferable to do a PET CT, but for you can also do a CCT if it's a result culture. It's preferable. And a PET CT to be done if it's non-metastatic disease or CCT.
Okay. Dr. Patla, would you want to say something? If the patient comes to you, what do you do?
Dr. Puneet, I will go for PET CT only when in other investigation there is no metastasis. We exclude certain metastasis. Avoid metastasis, we will go for PET CT.
What about the surgeons, Dr. Ahmad? How frequently do you get the PET scans done?
So, some amount of information I would have loved if I have got on upper GI endoscopy, like from where is the distance from incisors where the lesion is starting. Plus, regarding PET CT or CCT, TAP will adequately stage the patient. If it's like as per the upper GI endoscopy report, it's involving predominantly the cardia and the fundus of the stomach. Adeno-CA intestinal type PET CT have got good sensitivity. However, for non-intestinal type, your PET won't be that much sensitive. Plus, nodal staging also in non-intestinal type PET CT also again it won't be that much sensitive. So I would be quite happy even with going ahead with CCT TAP.
So precisely yes. So even the evidence-wise, evidence says that CT scan is enough to initially stage the patient. PET has evolving role in the management of G-junction tumors, and you may not do either way. You are right, and it also depends upon the availability of the imaging in your area of practice, where you're practicing, how easily it's available. And there have been some studies which have shown that some G-junction, a large registry study has shown that when the patients were managed with PET scan done at the baseline, there was some potential of showing a survival benefit in these patients overall.
May I make some comment?
Yes,
that is
sure.
because you upstage the patient.
Correct.
Probably you are considering the patients in a lower stage, and now you are picking up more number of dissemination of disease, and a good number of patients. Data says that at least 15 to 20% of patients will get upstage. So accordingly, your survival
Yes,
outcome
absolutely.
come different.
Just to add, if there is someone from nuclear medicine, with like in our previous institute, we have seen that with the addition of PAPI-PET, even with
We'll come to PAPI-PET sometime later in the discussion.
I think, can I chip in a little bit here?
Yes, sir.
Sitting in this chair as well as Pradipto sitting here,
Yes, sir.
Swapnil started with a case which is little advanced. Any gastroenterologist looking at the mucosa close to the junctions or just beyond the junctions will look into get something, maybe 5, 10, 15% situations. If we would have got an endoscopy picture, so there lies that the role of US, which is we will come
I
to
have
a case like that.
yes,
Okay, thank you.
So this was a CT scan of this patient which showed an irregular wall thickening and enhancement to the G junction, fundus and cardia of the stomach, and around 1.3 centimeters in thickness, and few perigastric nodes were seen, and essentially it was a non-metastatic disease. So what next? Dr. Pradipto sir, would you, with this imaging, would you suggest if there is any role of endoscopic
I
ultrasound?
think right now US is must for the local regional staging and mostly for tumor and normal staging. So before going for laparoscopy, US maybe you can take biopsy also on the local nodes, and for the staging US is a must.
So, sir, what are your thoughts on the expertise which is required for an adequate US to be done? So I say
those
this.
centers, those centers were doing US. Now US like a diagnostic endoscopy, colonoscopy. Those are trained, not like mine or our, but the new generation they are all trained in US. So picking up an node, which is suggestive of malignant or benign, is not significant. So US is very commonly done most of the centers. So there is no doubt. Only therapeutic US there is a learning curve. Other diagnostic US are definitely as in people, and most of the centers are doing.
I know something actually here. The development of the endoscopes, what they have done with either NBI or if you go to FISH or iScan, that you can see the mucosal, the vessels. The vessels, the interfactory capillary loop, the network, will guide us to the endoscopies on even day 1 of endoscopy or day 0 of endoscopy, that you know that what are the lesion you are handling. Is it in T1 within the mucosa? Is it involving the muscularis mucosa? Is going beyond, and that immediately in the same room you can shift your scope from your NBI to US and give to you a backpack or the referral physicians or the team in the hospital that this is a patient which I will not be able to handle you and you need more. So as soon as it goes beyond T1, T2 or the submucosa, then you, I think you need to know that. So their job, my job and Pradipto's job is over. We will hand over the case to the community.
So, surgeons, what do you think is the role of, is there any role for staging laparoscopy in this case, Suresh?
Yes, there is definitely a role for staging laparoscopy. The thing is, so if it is radiologically looking at diagnosis, in this case, the node is positive. It's a type 3 C-word classification. So according to which it is managed according to carcinoma stomach. So I'll go ahead and stage laparoscopy to rule out the peritoneal disease before deciding in the intended.
So you would say that staging laparoscopy for G-junction tumors has a probable node for C-word type 3 tumors, right? 2 and 3. That's acceptable because staging laparoscopy per se prospectively hasn't been assessed, or there is a very emphatic evidence for gastroesophageal junction tumors in particular. The evidence which we have for staging laparoscopy is again an extrapolation from the use in gastric cancers overall. But yes, C-words 2 and 3 are essentially managed like gastric cancers. So, word on early cancers of esophagogastric junctions and endoscopic management. Dr. Pradipto, sir, you would want to share your experience or around how frequently in our setting, like in Kolkata here or in your previous experience, how frequently have we seen these cancers in our practice, and are the cases being appropriately referred for timely management of these early lesions?
It's true that we get cases very late because those of dysphagia already there is 70% occlusion domain and they are beyond endoscopy management. So only if you are doing an endoscopy and suspect a lesion and take biopsy and confirm there is a T1 lesion, then you can go for endoscopy management.
Otherwise, most of the patients, except few odd cases or few patients are referred for the management. Otherwise, don't face early cases, don't get early cases. And if you are doing a program, surveillance program for parents, then only better dysplasia, then manage them typically, depending on expertise. Because most of us who started doing this EMR or ESD, they are comfortable in say to do with stomach, rectum, and the last one is the esophagus. Okay, so all depends on expertise. A few centers are doing esophageal lesions, ESD or EMR, and anyway getting less amount of patients, expertise also less. So numbers of cases done in our center or few centers doing advanced procedure less.
So most of the evidence which we have around the management of endoscopic management of these early cancers, I feel is from the Korean and the Japanese population because they have a very strict screening program. And like I was in Korea 2 months back, and what I got to know, it was interesting that everyone above the age of 40 years is screened with an endoscopy and upper GI and a lower GI scopy. And 30,000 gastric cancers are diagnosed every year. Out of these 30,000 cancers, nearly 50% of these cancers are early cancers. And nearly, so overall 30% of the gastric cancers are managed endoscopically. So moving ahead, so staging laparoscopy was done for this case, and there was no peritoneal disease, and even cytology of the peritoneal washing percent and the cell block analysis also did not reveal any signs of metastasis. So, Dr. Sudeep, neoadjuvant treatment or a direct surgery, this lesion appears to be probably T3 lesion and maybe N1 disease.
Yeah, of course, there's strong evidence for neoadjuvant therapy. There's no doubt in that. In any good oncology center where there's a tumor board consisting of radiation oncologist, medical oncologist, and surgical oncologist, which we always do. If Shiniket is here, Arindam is not here, they always discuss in tumor board all their esophageal or stomach gastric cases with us. And they themselves advocate that this candidate is eligible for neoadjuvant therapy. Only when we don't advocate neoadjuvant therapy, suppose a patient is bleeding, there's a lot of hematemesis or melena. So in such situations, probably we start with neoadjuvant chemotherapy or hemostatic radiotherapy, and still the bleeding is not controlled. Okay, do the gastrectomy first, and then we'll give the adjuvant chemotherapy. Or a very elderly, frail patients, when we are not sure to offer that how he will tolerate neoadjuvant taxane, because these days we have moved from magic trial ECF, neoadjuvant ECF, we have moved to FLOT regimen. So docetaxel, oxaliplatin, and 5-FU, that is the standard regimen, because that gives you a median survival of 50 months, or close to 50 months, which is unheard before this law. So any elderly patient, 65, 68 years, 70 years, poor nutritional status, albumin is low, low ejection fraction, or a lot of other comorbidities, he will not tolerate FLOT very well, and probably we will deny him the actual curative modality, surgery. So it's better to do the surgery first, and then if he comes out from perioperative morbidity, then we can offer him adjuvant
So
therapy.
we often have this, and I think surgeons would also want to pitch in this. In tumor board discussions, often we have this discussion because especially around patients who are not that fit, maybe let's say PS2, whether to give chemotherapy, we'll send from our end, please give neoadjuvant chemotherapy. But as you rightly said, that if the patient is not fit for a complete FLOT regimen,
sometimes we modify it, either FLOT, we minus oxaliplatin, or we reduce the dose of taxane, you know. So, but once, at least one case every month comes from Arindam and Shiniket, whose ejection fraction will be 40%, and a lot of comorbidities, 70 years age, but they want me to give them neoadjuvant chemotherapy. And I say, see, neoadjuvant chemotherapy is neoadjuvant, it's not the definitive treatment. And if I give him neoadjuvant, if he lands up in febrile neutropenia, and then he actually will deny the curative modality treatment. Okay.
So, Dr. Swaratika, any additional comments on this?
So, I actually, I differ slightly. I would actually, because if a patient is not fit for neoadjuvant chemotherapy, the patient is likely unfit for surgery as well. It's tough to operate these tumors, it's tough in perioperative period also, and it's really difficult to give adjuvant chemotherapy. The answer is easier when it's an adenocarcinoma because you can definitely go ahead with surgery and you have some adjuvant therapy options later. It becomes dicier when it's slightly T1 or when it's squamous cell. The answer is even more difficult because I have personally found giving FLOT to be easier than giving ECF or ECX. I don't have such a problem with FLOT, but the most important aspect is when they're doing the diagnostic endoscopy, if they find any features of obstruction, to put in a RISE tube at that time so that a definitive nutrition support, like a medical nutrition therapy is there, and it gives us 2 months period to build up nutrition. It won't change the EF, but I don't find FLOT to be so difficult to give. I think I find PACIS is definitely more difficult to give than FLOT.
Dr. Bhattacharya, would you want to comment neoadjuvant chemoradiation for G-junction tumor for this patient?
Yes. If the patient presents with severe dysphagia, I personally prefer to go for 2 to 3 cycles of neoadjuvant chemotherapy followed by chemoradiation and followed by PET-CT, response assessment followed by surgery. And unless patient present with severe dysphagia, then I prefer to go for straightway chemoradiation and followed by PET-CT done for response.
So, sir, if logistics of the place are not a constraint, would you prefer neoadjuvant chemoradiation directly, or would it be neoadjuvant chemotherapy first and then see the response and then plan for neoadjuvant chemoradiation?
Actually, patients on neoadjuvant chemoradiation, they face severe esophagitis and the symptom of dysphagia worsens at times. That's why if we start with neoadjuvant chemotherapy, 1 to 2 cycles, then dysphagia relieves somewhat, and then patient can tolerate well with neoadjuvant chemoradiation. That's why patient who presents with severe dysphagia, then I go for 2 cycles of neoadjuvant followed by chemoradiation, and after that, response assessment. I use Hallfox regimen, and in chemoradiation, either Hallfox component or Paclitaxel carbo weekly concomitant.
Yes, sir. Yes, sir.
I think histology will guide you that which neoadjuvant strategy to choose. Okay, whether it's squamous or adeno.
Regarding this treatment, I think I walk in also medical centers and Kolkata and everywhere. It depends on my approach will depend not only on the books, but my institutional availability of treatment. And number one, the site of the patient, whether it is near a gastroesophageal junction or just in the fundus, residuous type 3. If it is just in a gastroesophageal junction and any patient comes with bleeding, as he told, even the radiation neoadjuvant chemotherapy will control the bleeding. And there is, if the lesion is in the fundus, then I think that neoadjuvant chemotherapy may help. Neoadjuvant chemotherapy followed by chemotherapy, though there is survival advantage. Sometimes it happens, suppose in Calcutta there is Kimsukdas would be, they will dilate the esophagus and I can do neoadjuvant chemotherapy. But in the peripheral centers, there is no such feasibility of this. So if the patient comes to the dysphagia, grade 3 or 4, sometimes neoadjuvant chemotherapy relieves the dysphagia and you can do for neoadjuvant chemotherapy. So the approach of treatment depends on many factors.
Yes. So surgeons, what would you say, Dr. Amar?
What I was trying to convey said, if you do the cross-trial cross-section, subgroup analysis, you will see the squamous group after neoadjuvant chemoradiation, there was a complete pathological response rate close to 30%. So this is the histological type, they get the maximum benefit with neoadjuvant chemoradiation. 30% PAT-CR rate. However, the PAT-CR rate is not that impressive in adenohistology. Okay, so we are not we don't strongly advocate neoadjuvant chemoradiation in adenocarcinoma type because their failure pattern is something different. We feel they fail mostly in systemic sites, so probably local therapy neoadjuvant chemoradiation is not that great. But and in fact nowadays the concept is coming that with the surgery in squamous, whether surgery is needed after neoadjuvant chemoradiation. If there is endoscopically and radiologically there is complete response, if you can put the patient on close surveillance. Okay, so that I am not saying that has become a standard of care, but that concept is also coming.
So, for most parts, I will agree with Sudeep that in this case, particularly, I won't give neoadjuvant chemoradiation. I will go ahead with neoadjuvant chemotherapy only. Even if it's a CBER 2-3, in most of the cases, I will go ahead with neoadjuvant chemotherapy only, not chemoradiation. If it's if it's lower esophagus, like CBER type 1, and if it's squamous cell, as Sudeep told, I would have gone ahead with neoadjuvant chemoradiation. But even if it's lower third and it's like CBER 1 and it's adeno-CA, as what Sudeep also told, as per the cross-trial, I would have given neoadjuvant chemotherapy only, not NSCTI. Most of, yeah.
Okay, fine. So we'll move ahead. So there's a lot of evidence. I'm not going to delve deep into the evidence. All of us are mostly related to the latest, all the trials. So this is the patient received 4 cycles of plot in this case, and this was the post-chemotherapy response assessment scan, and there was a partial response and irregular wall thickening and enhancement could be seen in the G junction and the fundus in the cardio of the stomach, and few nodes are still there. And sir, would you want to say on role of repeat scoping in this case after having given chemotherapy? Would you say
Yes.
that prior to going ahead with surgery, is there a role
I think
for?
to see the response, we should do a scoping, and we see many patients of many squamous cell carcinoma, they do well, and you don't find a lesion also sometimes. So I think this is the role of the scoping definitely.
And I think the role of scoping is more like Dr. Steve said, in those cases when there is a complete response, and probably you are also thinking that not to refer this patient back to surgeon. So to check for any residual disease, I guess. So Dr. Suresh, would you always get a repeat scoping done? And do you think it's going to help you in your surgical management after this?
So I think it's not always absolutely needed to do a repeat scoping. If you are, if the previous scoping, the one before chemotherapy, tells you exactly where the growth starts and the response is good. So unless my margins are not threatened, I won't do a repeat scoping.
So surgical approaches, I think for this case, what do you think would your the baseline scoping tended to disease starting at 38 centimeters, and the scan you can see that it's predominantly severe type 2 disease. How will you preoperatively plan the patient? Total gastrectomy, just an abdominal approach, or would you also take consent for a thoracic access in this case?
So the thing regarding G-junction tumors is the approach depends on multiple factors. It's about these surgeons, what the surgeon is comfortable with. But more than that, the anatomy of drainage. So type 3 tumors more tend to drain towards the abdominal nose. Type 1 tend to drain towards the mediastinal nose. And type 2 is it can go both ways. And one other thing is radiology will help guide us. So if there are mediastinal nodes and everything, so I towards doing a thoracotomy approach. And in this case, being type 3, So if it is involving distal 3 centimeters of the stomach, so according to Japanese guidelines, if the distal 3 centimeters of the esophagus is involved, you can go ahead with the total gastrectomy and transhiatal distal esophagectomy. And another thing, it would be beneficial to have a frozen section of stage operatively if you are going ahead.
So, question to any surgeons in the audience. Would histology also play any role in, anyone can take this, histology also play any role in deciding the axis? Suppose if it's a poorly cohesive carcinoma versus if it's a well differentiated adenocarcinoma at the G junction, T-word state 2. Anyone? Sir?
I believe a total gastrectomy is an inferior operation for Siemens 2. This is my personal belief. Time and again, I always do an intraoperative scoping because with MBI you can actually find change your margins on table. So it's very valuable. MBI before chemoradiation is important, but MBI after chemoradiation is also important because it helps you decide. So when you do total gastrectomy for a patient with Siemens 2, I think your proximal margin is inadequate. Many times, it's been 10 years, we've had enough local recurrence at the anastomosis because we've taken that decision. So I think for Siemens 2, message is clear, no total gastrectomy, please anastomosis within the thorax, go as high as possible. Siemens 3, of course, you can manage otherwise. Was that the question?
Yes, sir. That was the question. So the same thing, Dr. Amar, any personal preferences for a thoracoabdominal approach versus transthoracic approach or transhiatal approach?
So as told, like if it's a Sievert 2 or if it's a like Sievert 1 lower esophageal disease, in most of these cases I would like to do Ivor Lewis. LTA, it all depends, like the place where we have been trained, we were not much in favor of LTA as the post-op complications and rehabilitations were like slightly difficult. So Ivor Lewis would be the preferred choice for me. Transhiatal will, like all the like studies have shown that it has got equivalent results with the Ivor Lewis or with TT, but it becomes obvious to us or on visibility that the proper lymph node clearance is not there. Transhiatal we were doing only in cases where we have found that the patient is not fit for thoracotomy. Like if I am getting high-risk patient with low PFD in poor PFD, in those conditions only I will prefer transhiatal. Otherwise, I will use all.
Yes. So there have been two trials which have compared these approaches, the thoracic axis versus the transhiatal axis, the Dutch trial, and the thoracoabdominal axis versus the transhiatal axis. And the message is more or less the same thing. And you decide your approach based on the histology and all the parameters and the amount of lymph node dissection which you intend to do for your tumor. So I'll just skip this. So in this case, the patient underwent a Ivor Lewis partial esophagogastrectomy with an esophagogastric anastomosis. Intraoperatively, there was thickening of the fundus of the stomach as well. No significant nodal disease was found. Adequate lymph node dissection was done at all the required stations, and the post-op histopathology showed residual polydifferentiated adenocarcinoma by PT3 and N0, 0 by 28 nodes, and margins were free, and the patient was given adjuvant chemotherapy. So now coming to case 2, we have with us a 66-year male patient and presenting to us with the chief complaints of pain in epigastric region for a year with loss of appetite. Examination was essentially non-contributory, and an upper GI endoscopy showed a growth at G junction and cardia of the stomach, and biopsy showed a poorly differentiated adenocarcinoma. So we went ahead and did a staging laparoscopy, and the PCI was 0. This should have come first, sorry for that. So this was the CT finding, which showed a heterogeneously enhancing lesion in the cardia of the stomach, and few perigastric nodes were present. So, Dr. Puneet, Would you say now you're coming to PET scan? Would you, this poorly differentiated cancer, more amount of stomach is involved? Would you advise or advocate a PET scan in this case?
I would prefer to do a PET scan for staging of most of the cases.
So, in general, stomach cancers and especially the poorly coagulated cancers, the PET scan is more or less contributory to the overall management. But any thoughts on the recent molecules on fatty PETs or experience with that?
Okay, for stomach cancer, mostly for the segment is variants which we have a lower sensitivity, but poorly differentiated high grade adenocarcinoma, we tend to have a higher sensitivity. Coming to fatty PET, it's still in initial stages of evaluation, but it has been shown to reduce the false negative studies of FDG testing. So more likely to give a true positive study, but other limitations of FDG remain same as FDG testing.
So this patient received 4 cycles of neoadjuvant chemotherapy, and so on post chemo response assessment scan, there was an increase in the disease. There was an increase in the size and the extent, and there was a probable infiltration into the pancreatic tail, probably also going to the splenic hilum, few nodules, very regional nodes/nodules were seen, and initially there was doubt of some enhancing lesions in the splenic parenchyma, which however later were told to be were not that to be metastatic. They were parenchymal lesions. So, surgeons, what do you say? What next? Do you want to operate this patient?
Actually, so surgery in this case will be depending on the comorbidities and the expectation. Okay. So I'm going to do surgery. So my entire multi-vessel section, so with the gastrectomy and all the distal pancreas.
Medical oncologist, what do you think? Patient? Okay. Any thoughts on patient who not responded to 4 cycles of neoadjuvant chemotherapy? Trying something else? Anything in line?
No. I mean, I think it depends on whether this, because the patient has failed the best therapy which is there. So no amount of additional chemotherapy is going to change the biology of the disease. At this point, if it is resectable, we can go ahead with resection and explain to the patient that his chances of relapse is higher. So if he's a fit candidate for resection, to go ahead. Otherwise, you have to change the way we are managing. Either incorporate targeted agent, treat it like a second-line stomach with either an anti-HER2 or immunotherapy instead. And then that'll be palliative in nature.
Okay. So any thoughts on using anti-HER2 agents in the neoadjuvant setting or sleep?
In neoadjuvant setting, there is no proven role, there is no trial, and I don't think there will any trial will come up to explore the role of anti-HER2 therapy in neoadjuvant setting, because the presence of HER2 in CS stomach is close to 20 to 25%. So in such situation, I don't think any trial will come up. But of course, if you want to downstage the tumor, you can, and it is a HER2 positive, you can use anti-HER2 therapy, but that will be off level. There will be no survival benefit. But your primary aim in such situations is to downstage the tumor and make it operable for surgery.
So we did go ahead with surgery in this case, and the patient underwent a total gastrectomy with the distal pancreatosplenectomy with the left adenoidectomy and excision of involved portion of left diaphragm and transverse column. The postoperative recovery was good, and the patient was discharged within I think 2 weeks or something. And the histopathology, so surprisingly showed in this case, it was a PT4 and there was tumor. Histology showed a mixed neuroendocrine, non-neuroendocrine neoplasm, and all the lymph nodes were free of disease and the margins were free. And in view of predominant non-neuroendocrine component, patient was given 8 cycles of chemo in this case, and the patient continues to live and is disease free. So radiation oncology, yeah, please. Yeah, so because he didn't respond to this, and
equation. So I'm not sure if 8 cycles of K-box is better than 4 cycles of Flow.
Yeah, I'll have to check it with my own medical oncologist. Dr. Sudeep, any comment on this?
I completely agree, sir. The patient already was exposed to oxaliplatin and 5-FU. And
what would you have chosen in this case? What adjuvant would you have chosen or preferred in this case?
In such situation, I would prefer irinotecan based chemotherapy.
Change the backbone of chemotherapy, or maybe included, presuming that it's the neuroendocrine component which might have progressed with FLOT, give an agent maybe with etoposide to address that. But if you don't want to address that, I would either want to FLOT or changed with FOLFIRI or something different.
Any thoughts on adjuvant radiation therapy in this case? Anyone want to take up adjuvant radiation therapy for this patient? Dr. Batra, and so.
Adjuvant radiation. Okay, but you said that was approaching the spleen. And spleen is very radiosensitive, so I have to take care. The spleen is not getting the radiation.
So the spleen is gone, sir. We have removed everything, we have done.
Spleen is there now, then you definitely have, you can go for adjuvant radiation.
Any indications of any specific indications for which you would practice adjuvant radiation therapy for esophagogastric cancers or N3 disease? Would you, if the patient had N3 disease, would you give adjuvant radiation therapy?
Adjuvant radiation will just may reduce the local recurrence only. Otherwise, most of the cases will do neoadjuvant. Suppose the patient comes after surgery, then you can give adjuvant radiation to reduce the local recurrence only.
So, yes.
Just give a mic to.
At present, there is no robust evidence for adjuvant radiation in CA trauma, except if it is a T2 node dissection and after that there is a margin positivity, then only I will consider. But even if it is a node positive disease, when the RTC2 trial came, I will never recommend radiation.
So there is some retrospective data for some possible role for adjuvant radiation therapy in N3 disease, but yeah, as you rightly said, the data is not robust. And the main indication is margin positive resection.
Yeah.
Yes.
Even if it is a gastroesophageal junction tumor, then also there is no robust evidence of adjuvant radiation. But if you see what I will say that after the neoadjuvant treatment, obviously I will go for a neoadjuvant treatment if it is possible. But after neoadjuvant treatment and surgery, if there is residual disease and there is a non-PCR, then there is option of adjuvant nivolumab in this setting, but I will never recommend radiation, except if it is a margin positive, otherwise I will never recommend radiation.
So, if N2 disease,
Even if it is a N2 disease, yes, trauma, T2 dissection has been done, margin is negative, then there is no role of adjuvant radiation at this moment.
So coming to the last case, and we have with us a 63-year-old gentleman presenting with dysphagia and nothing contributed to examination. The biopsy this time for the growth at 38 centimeter was a poorly differentiated squamous cell cancer, and there was the CT showed a thickening at the lower esophagus and extending into the cardia of the stomach, and the PET scan also showed a non-metastatic disease, and this is the scans of the patient. So the same thing we have already discussed, neoadjuvant chemotherapy or chemoradiotherapy depends on a lot of things. And in this case, the patient was given 8 cycles of neoadjuvant chemotherapy, and this was the response assessment scan. And so surgeons, extent of surgery in this case, it's a G-junction squamous cell cancer, probably also involving the cardia. And what approach would you take, Dr. Amar, open or MIS?
Probably this will totally survived. And if
it's possible as the local burden which has been shown is not that much great. Yeah, so
the
in
response has been quite good.
pulmonary invasive, totally satisfied with diagnosis.
Yeah. So in this case, VAT totally through was done with the 2P lumpectomy, and margins were free and there was residual tumor seen. So, as we were discussing, Dr. Radhika, observation or any role of further treatment in this case?
See, this answer would have been evident if you had just given NSCT earlier, right?
Yes.
But you're not. But I would prefer giving immunotherapy because this patient has had chemotherapy, he's not had PAT-CR. So obviously with NSCT he might have increased the chances of PAT-CR, but he's not had it, so I would prefer giving adjuvant nivolumab if affordable.
So in this case, the patient was given an option of adjuvant nivolumab, but obviously because of affordability, they did not take it and was kept on observation. And so, okay, thank you.
I think that shows that it's a team approach.
Yes.
And if the dialogue becomes really important between the all people, and that was lacking in this city, at least if I talk about 10-20 years back. So the young people has totally changed the whole city. And we, the so-called elderly people, has to update myself, has to update so that I can just help you out or at any time learn from you so that we proceed and treat our patients in a better way. I think fantastic discussions, all of you, the panelists and the moderator.
Thank you, sir.
Thank you from me and co-chairs.
Thank you, everyone.
And thank you, audience, for watching.
Photograph.
Thank you, everyone. Let's start with the next talk. The first talk of the day, optimal sequencing for neoadjuvant therapy in CA rectum by Dr. Tapesh. He's a consultant in radiation oncologist at TMC Kolkata.
Hi, good morning all. And today I am going to discuss about optimal sequencing of neoadjuvant treatment in carcinoma rectum. So first I will start from the take-home messages. We all know that there is better disease-free survival with total neoadjuvant treatment comparing total neoadjuvant treatment versus CTIT. Today actually I will focus on total neoadjuvant treatment mainly because this optimal sequencing issue has come up after this TNT appeared. There is no difference in disease-free survival when comparing induction with consolidation chemotherapy. There is no survival benefit, overall survival benefit in any of the trials, and TNT is beneficial to achieve more complete responses. Consolidation chemo better than induction for complete responses and organ preservation. Increasing response with increasing number of cycles. So how I have reached that? This is a journey and I will discuss all of them. So if you see the timeline, you will find that TME evolved in 80s, there came short course radiotherapy, long course chemoradiation, and we have reached a plateau. If you see, in 2017, Stockholm 3 trial came, that is short course followed by delayed surgery, and the entire scenario changed in 2020, where these two landmark trials came, Rapido and Prodigy 23. You will see locally advanced carcinoma rectum, S-Morris classification. The ugly part is most challenging with C, T3C, MRF involved, liver threatened, lateral nodes positive, clinically T4A or T4B disease, and this is the most challenging areas. So before going to the ugly ones, let's see what good is. It's up to T3A disease, you can straight go for surgery, no need of any adjunct treatment. If it is a T3B, You can go for a short course radiotherapy followed by immediate or delayed surgery. Now comes the ugly disease, which is challenging, and there comes the TNT and optimal sequencing of treatment. So it is T3C and above, node positive, lateral pelvic wall nodes positive, EMPI present, MRF involved. So if we see the, so which option we will opt? Whether it is a long course chemorad, total neoadjuvant treatment. If it is a total neoadjuvant treatment, then whether it is short course followed by chemotherapy, or whether it is a concurrent chemoradiation followed by chemo, or chemo followed by concurrent chemoradiation. So there are a lot of options, which one to choose. So this is challenging. So what are the options of rectal cancer we have so far? Preoperative better than postoperative radiotherapy, we all know. Chemoradiotherapy was better than long course radiotherapy alone, proven. Long course chemoradiotherapy is equivalent to short course radiotherapy 5x5 proven in different trials. And short course radiotherapy followed by delayed surgery better than short course followed by immediate surgery in terms of downstaging and achieving pathological complete response. So if we see the short course versus long course, in terms of overall survival, this meta-analysis has proven there is no difference between the two arms. Again, short course versus long course, 3-year local recurrence, similar. If we come to the Stockholm 3 data, it has shown that delaying surgery after short course radiotherapy gives similar oncological results compared with short course radiotherapy with immediate surgery. And although radiation-induced toxicity was seen after short course radiation with delay, post-operative complications were significantly reduced after short course radiation. And if you see the PCR rate, it has significantly changed with delayed surgery, 12% versus 1%. So now comes the role of TNT. When to give total neoadjuvant? Locally advanced rectal cancer, yes. Patients with high propensity of distant metastasis, like EMBI grade 3, grade 4, say lateral nodes positive, multiple nodal involvement, and obviously as part of an organ preserving strategy. So what is the rationale for TNT? Yes, earlier use of systemic chemotherapy will take care of your micromets, better compliance with neoadjuvant treatment, maximal downsizing of tumor for better tumor control. What are the TNT approaches? First one is like the rapido one, that is short course followed by chemotherapy followed by surgery. Second one, chemoradiation followed by chemo followed by surgery, or chemo followed by chemoradiation followed by surgery. These are the 3 different TNT approaches currently available. So first, let us go to the rapido trial. In Tata, we are practicing a lot of rapido. So what was the rapido? Standard arm was concurrent chemoradiation, and the experimental arm was short course radiotherapy followed by 2 weeks gap, then 6 cycles of K-POX or 9 cycles of FOLFOX, and then surgery. So what was the rapido outcome? Yes, disease-related treatment failure better in the TNT arm, 6 to 8% benefit. Distant metastasis was less in the TNT arm, that was 20% versus 26%. Local failure, not much difference. Overall survival, there was no difference. If you see the PCR, TNT, it was double, 28% versus 14%. So if we see the pattern of failure in the rapido trial, you will find that if you see the lung, liver plus lung, there was not much difference between the 2 arms. But if you see the liver only metastasis, yes, experimental arm or the TNT arm has done better as compared to the standard of care. But we don't know the exact reason of this. And this is a big criticism came from the surgeons. This trial was published in Annals of Surgery in 2023 that rate of local regional progression after rapido is high in the TNT arm. So if we see in the initial years, there was not much difference. But in the R0 resection group, 5 years and down the line, the local recurrence increased in the TNT arm as compared to the standard of care. And similar for the R1 resection patients. But we have to analyze it properly. If you see that disease-related treatment failure was still better in the TNT arm, and this local failure was included in that. So question comes that whether 5x5 is enough, or you need a boost in the short course, or you need a long course chemoradiation. But let us see the disease characteristic. So it was 12% versus 8%. Failure, and if you see in this trial, it was the mesorectal breach. Actually, that has a major impact on this late local regional progression. And if you see the rapido data, you will find that T4 disease was quite higher in the rapido. It was 31%, clinical N2 65%, MRF 61% versus the concurrent chemoradiation TNT trials. Enlarged rectal nodes were high. So basically, you are dealing with a very bad disease. And that has shown that maybe 5 into 5 was not enough. But we can't criticize it directly. So if you see the comparison of characteristics in different trials, again you will find that this Polish and Stellar, these two are also short course radiotherapy TNT trials, where again T4 was high, 63%, MRF in Rapido was 61%, Stellar it is 56%. But if you see the CTRT, concurrent chemoradiation TNT trials, Prodige, CAO or OPRA, the disease pattern was not so bad. So these are the TNT published trial of short course, and these are the last 3 are for the long course chemoradiation. So let us see the TNT DFS. In the short course group, Rapido has done better. That was 76% versus 70% disease-free survival, so 6% benefit was there. But other 2 trials shown similar results in both arms. If you see the concurrent chemoradiation, there is induction chemotherapy followed by concurrent chemoradiation or concurrent chemoradiation followed by chemo. So only the Prodige trial has shown that in the induction arm, it was 76% versus 69%, which was better. Other 2 trials have shown there is no difference between the concurrent chemo followed by chemo or chemo followed by concurrent chemoradiation. So if you see this meta-analysis published in 2022, that is TNT versus CTRT, yes, DFS and OS was slightly better in the TNT arm as compared to CTRT. If you see the complications, there was not much difference between the TNT and CTRT. PCR, obviously, TNT arm has done better as compared to the chemoradiation arms. So if you see that there are 2 kinds of organ preservation approach, one is the primary one and another is the secondary one. Primary one, it is because for the early tumors, primary use of chemo or radiation with the aim to avoid surgery in whom chemo or radiation is not indicated in the adjunct setting. But here, we have to mind that toxicity is a failure. You are trying to avoid surgery, you are dealing with the early patients, and you are giving toxicity, then there is no point of such kind of strategy. But if you are planning for a secondary organ preservation, like most of our patients for advanced tumors, T4, N2, lateral rectal nodes positive, yes, I have given some form of TNT, be it a Rapido, be it a Prodige, be it a OPRA, and the patients who have achieved clinical complete response, clinical radiologically complete response, then whether we can preserve the organ. So if there is such kind of response, they are lucky chaps, so organ preservation is a strategy. So what is the optimal approach for TNT and complete response? Should we start with chemotherapy or radiation? Which radiotherapy schedule is best? So if we see, these are all the trials I have already mentioned, Rapido I have discussed. Let's come to the next short course trial, that is a Stellar, where it was control arm was concurrent chemoradiation, same, and experimental arm was 25/5, 4 cycle of Capox, and then TNE and 2 cycle adjuvant. Here what we found, it was mainly the T3, T4 and node positive disease. And if you see in terms of difference, yes, overall difference there was slightly better in the TNT arm, and local regional recurrence was slightly better in the TNT arm, but there was not other difference. And if you see the PCR, TNT has done significantly better, that was 22% versus 12%. If you come to the Polish 2 trial, palpable fixed T3, CT4 disease, experimental arm 25/5, instead of 6 or 4 cycles, they have given only 3 cycles of Folfox and then TNE. So what was the result? There was not much difference between the chemoradiation and TNT arm. And if you see both in terms of overall survival and disease-free survival, not much difference. But obviously in the TNT, PCR was better, that is 16% versus 12%. So if you see the comparison of all PCRs, Polish 2 TNT 16% versus 12%, Stellar TNT 22% versus 12%, and Rapido TNT 28% versus 14%. So if you see all the trials, control arm has given you the similar kind of PCR, but the TNT arm was significantly better, 22, 28, and 16. So whether it is the more response with increasing chemo or more response with the extended interval. So this is a big question. So if you see the Polish TNT, 3 cycles of chemo, PCR 16%, Stellar TNT, 1 extra course of chemo, there is 4 cycles of chemo, and then there is a 22% PCR, and Rapido, 3 more courses of chemo, and also the extended interval, and it is 28%. So whether it is extra chemo or extra time, and if you see the number of courses of chemo, then you will find that this was the trial from the Agulier in Lancet published in 2015. So they have given the standard thing, and then there is a modified Folfox 2 cycle, time gap has increased. Again, group 3, modified Folfox 6, 4 cycle, again the extended interval, and in the last group it was 6 cycles, so your time gap was further increased, and you have seen that PCR rate is increasing from 18, 25, 30, and 38. This was a trial published in 2013. you can see that after 16 weeks of neoadjuvant chemoradiotherapy, we have reached a plateau. So after 16 weeks, it is not giving you much benefit in terms of PCR. So here, if you can draw a line around 16 weeks, ideally it should not increase the PCR rate. But from this, you can see that obviously chemo has some impact. When it has increased from 3 to 4 to 6, your PCR rate increased. So it is not only the time interval which is important. So what about the CTRD-TND trial? These are the trials, and I will come one by one. 23, that is modified FOLFIRINOX, followed by chemoradiation, followed by surgery, and there were some adjuvant chemo was there, and the standard CRT. If you see the disease-free survival rate 3 years, obviously TND arm has done better. And if you see the PCR, again it is 28% versus 12%, again significantly increased, and the control arm remains the same, but TND arm almost same like the Rapido. Whether this was another trial, OPRA, where they have timeline has not been changed, only they have changed the sequence. Chemoradiation followed by chemo followed by surgery, or chemotherapy followed by chemoradiation followed by surgery, and the patient who has complete response or near complete response, whether we can do organ preservation or not. So what was the OPRA trial outcome? Yes, there was no difference between the local recurrence-free survival, disease-free survival, or overall survival. But what was the difference? Difference was in the regrowth. The patient who has got chemoradiation upfront, their regrowth rate was low. And the patient who has got upfront chemoradiation, their TNE-free survival was better. So in terms of organ preservation, this group has done better, where we have started chemoradiation upfront as compared to the chemotherapy. If you go for the COARO trial, yes, they have also done the similar thing. They have only tested the sequence rather than changing the timeline or changing the chemo. Again, you will find that disease-free survival and local regional recurrence were similar. But again, the PCR rate 25% to 70%, again, organ preservation was better when you have started with the chemoradiation as compared to starting with the chemo. So here you can see the complete response in the OPRA induction chemo 43, consolidation 58%, increase, ARO induction chemo PCR 17%, consolidation chemo 25%, again increase. The interval between start of surgery and therapy and surgery in both arms of both the trials remain the same. This answer is pending, whether short course is better, whether long course is better, this trial is pending. So we should go for a risk-adapted radiotherapy approach. High risk of local recurrence, MRF involved, T4 disease, sphincter involvement, positive lateral lymph nodes, or whether it is a high distant metastasis like EN2, tumor deposits or EMBI. So first group, I should go for RT or chemorad followed by chemo. The next group, I should go for chemo followed by chemorad. That will be a better approach. So this trial came recently. There is a prospect published in NEJM. So whether it has real prospect, so let us see who are the eligible patients. There was T2 node positive, T3 node positive, T3 node negative. So these are basically a favorable group of patients. T4, N2 less than 3 mm from MRF excluded. So whether we can omit radiation or not, this was the question. Chemo versus chemo radiation. So what they have done, participants in the experimental group were at stage after chemotherapy. If tumors regress by more than equal to 20%, then the participants bypass radiation and underwent rectal surgery with a total mesorectal excision. Or participants with suboptimal responses, less than 20% tumor regression, received chemoradiation before surgery. So whether it has helped, yes, non-inferiority was proved. But mind you, these were all favorable group of patients, and grade 3 toxicity was much higher in the chemotherapy as compared to the chemoradiation arm, and that was 43% versus 22%, mainly in the form of neutropenia and neuropathy. So these are our examples. We have given Rapido almost more than 100 patients in our center. So it is a low rectal disease. Here you can see this was not a good one, and there are mesorectal nodes present. And after the short course and chemo, before surgery, there was a complete clinical response or radiological response, and this patient has achieved PCR. Again, this is another example where it was a mid and upper rectal tumor. Here you can see, and this was also treated with Rapido, and this has shown excellent response. This was a PCR also. This was a prodigy example. A young guy, 21-year-old, with HIV positive. This patient has a multiple nodes. You can see there were inguinal nodes were also there, but there was no other distant metastasis. We follow the prodigy protocol because of multiple nodes and bad factors. So here also you can see this patient has achieved excellent clinical response, and also this patient also achieved PCR. So in Tata, this was 2021 to 2022, 72 patients were treated. We treated 72 patients out of 46 patients underwent surgery, 26 could not because of patients defaulted, there was disease progression, and so on. But in the main Rapido trial, 92% patients could complete surgery in the experimental arm. And we have achieved 24% PCR. So our PCR rate was 24% as compared to the original rapid trial, 28%, but mind it, it was a real world data. So what are the take-home messages? I started with this, and the same take-home message I want to convey. And what are the questions unanswered? Difference in metastatic pattern, why there was a liver-only difference? What is the optimal number of consolidation chemo courses? Is 5 and 5, 5 into 5 not enough for local control, and should we boost? Whether we should go for higher dose or we change our strategy. TNT required for RT tumor with low metastatic risk, whether it is required. RT with immunotherapy may change the scenario further. Thank you for your kind attention.
Thank you, Dr. Bhatia, for your excellent presentation. Is there any question from audience? So, if there is no question, then I can conclude this session.
Thank you.
Right.
Thank you so much, Tavish. We'll go on with the next talk. Beyond TME and extended TME, role of MIS. Dr. Avanish Shaglani, Professor and Head, Colorectal Services, Department of Surgical Oncology, TNH Mumbai. I guess sir has just arrived. Braving the Calcutta. Come from Bombay, Calcutta, where there should not be a surprise to you. And welcome.
Hi, good morning everyone. It's such a great pleasure to be here. I would like to congratulate Medica for inaugurating their new branch there. And main thing for coming here is of course to meet all our alumni, syndicate, income, and so many people from the thing. So I wish you all the best in your ventures there. So I think I did a great presentation with my radiation on medical oncology career. But it's what you see. Normally when you see a glass, or someone sees a glass half full and you see it empty. So they see successes with therapy, I only see failures. So all those, my topic is only about failures, about beyond TME and extended TME. I'm Dr. Saklani, I come from Tata Memorial Hospital, I think, which is our matter for almost all of us. So this is the GI DMG group, which includes all hepatobiliary. So I present, I'm the convener for the GI DMG group. Right, it's difficult to get forces together which put different charges. Okay, so the radiation oncologists think they are the best, medical oncologists think they're going to cure everyone, and the surgeons, of course, they're no into their arrogance. And to get all of them to sit together in one photograph is an achievement. And imagine if you're going to sit down and discuss some cases and say, what are you going to give, Rapido, Prodigy, or you can sometimes pull each other's hair out, but we still manage. And finally, we come to decisions. And the decisions for rectal cancer are normally we give all this treatment, and sometimes the outcomes are really very good, and it is clinical complete response. And we compliment ourselves that we have given a great treatment, but it is probably the tumor biology of the patient. On the other hand, the outcome may just be okay, good response, but not enough. And then you do standard TME surgery. When you come to TMH, most people who come are young, challenging, and they may not have good response. So the tumor goes beyond the rectum into surrounding organs, prostate and bladder, and then you do extended or beyond TMH or excentrations. So normally if you look at it over 10 years time, so we have done about 364 excentrations. Compared to the Western world, we do more excentrations for primary cancers compared to recurrence. So about 155 minimal invasive excentrations, which are probably the largest in the world. So 110 total pelvic excentrations MIS, posterior excentrations of 45, and bladder scanning of 19. So when we moved to India in 2013, and all we had were cancers like this, mucinous tumors which are involved in seminal vesicles. And if you look at them, amount of T&D therapy is going to make a solution out of them, and they ended doing a lot of multi-lateral resections. And then the amount of minimal invasive surgery was very less. So then we thought probably if we want to do more, we have to do more procedures. So then we started expanding. I think we're doing minimal invasive for seminal vesical excision, prostate, and things like that. And we probably have the largest series of extended TM. So if you involve only 2 or less organs in procedures, that will be called extended TM. Otherwise, it will not be on TM. The most important thing you have to do is stepwise patient. We became better at TM. We did about 1,000 MIS rectal resection, pelvic node dissection, which is the most important component. We did quite a few of those, and we got better at that. And over a period of time, we decided to. Because you have large numbers, so we did about 3 months, we did about pelvic exentration, about 10 of them. And we were able to form a conduit, and there was no mortality, so everything looked fine. With formation of this taking the rectum and bladder, obviously you have to think about the conduit, radiologically so busy, and we have to think about ourselves. So you formed either a breaker or a Wallace. This was done through mini laparoscopy or through the stroma itself. We could do it intracorporeal as well. So I'll just So because there are many surgeons in the crowd and the attention span of surgeons is very less, so I said probably they put a few videos itself. So normally this is just a thing about robotic sort of thing, which I'm sure Medica should be given as laparoscopy is coming, CTK is quite well trained in them as well, and MIS of course has to be done. And I'm sure over the next year or so they should probably get robotic system as well. So these are good systems, and we can do finer dissection for more than simple procedures. Here you can see the images are pretty good, and you're doing a standard DME procedure. You're going to either rectal plane DME. So we do a lot of laparoscopy and robotics, so the advantage of robotics for us may not be much, but as you do more complex procedure, it gets better, and you have a trained team, then you can do better as well. So this is going in a posterior plane or TME plane sort of thing. I think what we've seen in surgery, what looks good is actually good, and the outcomes are better as well, so it's better to have a clean plane there. idea is to just see what sort of thing is there. So first part is bedside the rectum. So this part of the rectum will go behind in the DLE plane and reach the pelvic floor. The next part would be to do pelvic node dissection. So this is what normally colorectal surgeons won't be doing more commonly. So we do lateral node dissection, we dissect the ureter and dissect all of the vessels. You have a lot of anatomical variations. You have the obliterated and sometimes superior lines can become quite early. You dissect the nodes around the iliac vessels. For rectal cancer, normally you focus more on branches of internal iliac vessels, so you're not actually addressing the external iliac nodes. So with good control, you can actually decide the anatomy. You can see the bifurcation of external and internal iliac vessels, define the obturator nerve. You take the obturator vessels as well. For most of the procedure, they are normally all this node dissections are normally staging procedures, and you compound that by giving chemoradiation sort of thing. But for these people already had all therapy, radiation, chemotherapy. So when you do procedures like this, you have to make sure that entire lymph node package is removed, so there is no local recurrence. The idea of integration is to have very low local recurrence, even lower than rectal resection sort of thing. So here you clear the obturator node. Now you clear all the branches of internal iliac as the pudendal going into the pudendal canal. There's a large model of the pudendal vessels that you can take that as well. And the most important thing is to clear inferior vesicle node around the inferior vesical vessel. That is the Achilles heel for this one. Most recurrence is after pelvic node dissection at that point. So, and if they come back, you may have to end up with uterine dissection. So we try to take this out of the packet. I think when seeing Kate and Arina start their practice, I think the most likely case that you're going to get a probably recurrent or extended dissection. So if not clearance, you can see the ureter, the apogastric nerves, and all the other iliac vessels. So if this was a plan to do an exentration, then you would have to cut the ureters and form a bladder and form a content. So now if it's an exentration, what you do, just cut off the ureters, mobilize it proximally, take the bladder down. And you get the easiest part sort of thing. So the rectum is already excised, the pelvic node dissection is done. You do an excision of the bladder, and the last part is formation of the control. So normally the DVC complex, you can take it out from below. Compared to radical cystectomy, in these procedures, the rectum slightly higher risk patients, what we can do is we can preserve the left coil and you can use the sigmoid brought out and regulators are joined in there and you can make a transverse stoma. So that's a very high risk patient advanced case. I think this is the best one to do to save it sort of time. And so you may hit I think you can do the same thing with laparoscopy as well. We move on to others now. So we can do the same thing with laparoscopy as well. If there is only seminal vesicle involvement, then we can just excise the seminal vesicle. We won't go into details now. So I think over a period of time, all the trials for rectal cancer have only looked at basically not advanced T4 cancer. So you have to look at data for this. So we published a result for MIS versus open acceleration in the first 64 cases, and the oncological outcomes were safe. We found that at least the advantage of MIS was, as you can see in this procedure, the blood loss is less, the wound infections are less as well. We doubled our numbers to 128 cases and the oncological outcome was maintained. So most important whenever you do data, I think Srinivas and all start to maintain a database so you can audit your own result and you can improve your outcomes just by systematic audit. All these procedures are not without complications and you see how to get your complications down. This was the thing about your reconstruction thing. And we have tried to do things to improve outcomes. For all those people to decrease this urinary complication, we devised another procedure called bladder sparing indentation, which is a good one. We again won't go into details here. Here we dissect the central vesicle and the bladder and suture the out the bladder. Still not without problem. So I think all in all, for locally advanced cancers which have not responded to individual therapy, you can offer exemptions. 5 years survival are more than 50% for primary cancers and 40% for recurrent cancers. They are not without complications and an experienced team is required. I think Medica has an experienced team in the Srinivas and I'm sure they'll be able to take on this challenge. I wish them all the best for their ventures. Thank you very much.
Thank you, sir, for an excellent demonstration. Dr. Makun Shah is here. Sir, you want to pass anything, any comment on this? Give a mic to Makun sir. Makun sir.
Very nice presentation from a renowned faculty, and you see this surgery evolving, and with robot you can do it more precisely. Previously with such advanced disease, it was inoperable, and we say this inoperable, life is restricted. With this sort of excellent surgery provided, patient does not distant intracranial disease. These are all for locally advanced disease where can provide a cure. So this surgery is feasible, and I hope we'll be able to do more and more with advent of robot. Thank you.
Thank you, sir.
So moving on, top 3, role of immunotherapy in biliary cancer. Dr. Avinash Mona, Senior Consultant, Medica Oncology, AIG Hyderabad. Sir.
thanks to Team Medica for organizing this and inviting us. Very special thank you to Sudeep, Pradeep, Harsh, Kaushik, and the entire team, and all the very best for the future endeavors. So I'll very quickly move away from way down to way up. So I'll take you through a very small but an evolving topic about the role of immunotherapy in advanced BTC. Because this is a very challenging and perhaps a very difficult area and difficult water to treat. So we know that the incidence of biliary tract cancers has been increasing, and this is there since for the past 4 years, where we have data where it's on rise both in males and females. And these are the cancers where, at least in the West, more than 70%, and in India, of course, more than 90% of the BTCs are diagnosed in an unresectable stage or advanced stage. So for us, nothing much has happened over the past, it took really a decade to actually bring something in addition to the standard of care. Whatever we do, the outcomes are still dismal. The median overall survival is less than a year. So, and it's not just so simple that the BTCs are, epidemiologically, biologically, as they are a heterogeneous group of diseases. And whatever they are, still you can look at the outcomes which are just in single digits. So for the past a decade or more, even today, the standard chemotherapy backbone remains to be gemcitabine, and this has been established way back in 2010 with a single study. And we still continue to use it as a backbone. And a couple of friends have tried to, make gemcitabine more feasible for a certain population of patients where, with lesser incidence of hematological toxicities or patients who have borderline renal and cardiac functions. GemOx can be considered as an alternative to gemcitabine, and yes, of course, we use either of them in the clinical scenario. Now, if you look at this NCCN recommendations last year, well, the preferred regimen was gemcitabine and nothing else. But now in 2023, the scenario has slightly changed. I will not discuss the rant of trials and run around about the IO. I'll discuss just one trial which has, though not a significant difference in the outcomes, but yes, a relatively modest or at least something which has started putting the role of IO upfront in managing BTCs. So this is a TOPAZ-1 study which took locally advanced or metastatic BTCs, both intrahepatic, extrahepatic, and GB cancers. And it was a randomized study which gave gemcitabine plus durvalumab followed by durvalumab maintenance. The primary endpoint being overall survival and a whole of other secondary endpoints. So what is important is what I feel as a medical oncologist we look at is the population which is represented, and we had a good amount of Asian population which is represented here, close to 50%, and a fair amount of intrahepatic cholangios, and the rest is close to 55%, and GB 1/4, and extrahepatic around 20%. So PD-L1 expression and MSI, they were mentioned. Ongoing treatment, this is important because in the study arm, around 18% still were taking treatment. And one important feature here is that if you look at the subsequent anti-cancer therapies that the patients in the study arm received, they were closely matched. Like 40% of the patients in Durva Gemcis also received the subsequent anti-cancer therapies after progression. So this is the first and perhaps the only IO combination along with chemotherapy which actually showed some, I call it relatively modest, but definitely pointed us in a direction that, okay, yes, you can use IO in the first line setting in metastatic BTCs. So this benefit was seen across all the subgroups. I will show you the real world data. This is the trial data. But yes, this is a pointer, definitely, that instead of using or reserving IO to the later and subsequent lines of management, it is probably that you just have to put the plug a little earlier. So this, what is important is that this statistically significant, PFS benefit was also demonstrated. And this is again seen in various subgroups. I'm not talking about the magnitude of benefit. As I told you, this is a pointer trial or a direction trial which actually showed us that you probably can use IO in the upfront setting. The overall response rates also maintained to nearly a quarter of the patients, and this is beyond 1 year, which is important because, as I told you, crossing the 12 months landmark for a patient with advanced BTC itself is really something accomplishing. So, if you see that more than a quarter of the patients maintain their response even after 12 months, and this is something which we see across the immunotherapy trials. So what is important here is that patients who actually responded, they continue to respond better and beyond 2 years. So this is something which the curve separates beginning approximately 15 months after the randomization. This is something which is a hallmark of IO trials across most of the advanced solid tumor malignancies. Was it well tolerable? Yes. It did not have major, grade 3, grade 4 AEs. This is with respect to all AEs. And most of the AEs were related to the chemotherapy arm, but they were easily manageable. And if you ask me in the clinical practice, is it easily doable? Yes, probably. Handling durva in the clinical practice is okay. And if you look at the immune adverse events, yes, again, there were immune adverse events, but the grade 3 immune adverse events resulting in discontinuation of the treatment were not so much. So this is some regimen in advanced BTC in the first line setting, which can be handled day to day. But we need more and more rather predictive biomarkers or patient selection of the patient populations, or perhaps identifying which particular population of these advanced BTCs do well with IO in the first line setting. These are certain gray areas which are evolving. And after rather a decade, like since 2010, when we were in residence, we did not have anything apart from Genesis, and now we have something to add or offer to the patient with, again, a modest survival benefit. So we waited for a long time, and subsequently, though not yet approved by the FDA in the first line setting, it was followed up with the Keynote 966, which is another molecule that is pembrolizumab. Closely similar results, though not yet approved in the first line setting. Now, these are the list of the trials where immunotherapy was used in the second line setting. I'm not going into details of these because the responses are probably not that great. So what we understood over this past 1 decade and utilizing the immunotherapy or pushing it anteriorly or rather into the frontline setting in such cancers with dismal prognosis perhaps works. Now we need to tweak it or understand it more in order to identify which particular patient population will do well or worse, and how long and what to combine it with. So this is an area we have just started the learning curve, probably a long way to go. And so this is, we tried to analyze across 12 centers in our country. We put together the real world data of rather an Indian experience of using durva in patients with advanced biliary tract cancers. My friend took it to the ESMO GI Congress, and these are the participating centers across the country. We had around 75 patients which were included over a year. And if you can see, it was well represented when you compare it with the original trial. We had predominantly GPs. The cholangios were less than 50%, but we predominantly had GB. And majority of them received, like close to 93% of them received it in the first line setting itself. And the chemotherapy, of course, since it is a real world, we had combinations of Gemcis, Gemox, and others. And majority of them were metastatic. One important feature of the durvalumab, or perhaps the TOPAZ study, was that this benefit of IO or adding IO was seen across all molecular subgroups. Now, the current recommendation or the current way to go about when we need a patient with biliary tract cancer is to subject them for molecular profiling at the baseline itself. Though we don't do it because of various financial or various other reasons, but cholangios or BTCs, molecular classification or rather molecular profiling at the baseline is one of the recommended things. So we were able to do it in only 32 patients across, and you can see that the HER2 was there in 3 patients, and RAS was seen in 6 patients, and P53 of course seen in 7 patients, and PD-L1 expression, there is a it has to be taken with a pinch of salt because across the BTC, and the data has not actually pointed PD-L1 as a good or a reasonably good enough predictive marker in order to predict the response to IO. So it doesn't matter even if the PD-L1 is positive or not, because the response rates with immunotherapy have not, they were not significantly different across these groups. But probably we need something more rather than just doing PD-L1 in advanced solid tumors, especially if you take the BTC in concern. So our overall response rate was around 39% with the CBR around 64%. And this is the overall PFS, and this is the PFS subsite specific GBC and the cholangios. Relatively similar to the pivotal trial, but of course we had poorer outcomes with gallbladder cancer. I mean, we need to look at it more closely, and perhaps our overall survival could not coincide. I mean, we could not coincide with the pivotal trial because the subsequent lines of therapies received by our population were very limited, so that definitely affects their overall survival. So the toxicity, as I told you, it is reasonably manageable. Majority of the times the toxicity was more related to the chemotherapy backbone rather than just the IO. So at least what is more important is that again in India, we have a wide variety of dose representation here, because I've seen patients who have received 500 milligram, 1000 milligram, and 1500 milligram of durvalumab. So again, so this the real world data is something which we always look at it and then compare it with the trial data. So this is one of the first, a good number of patients, like 75 patients receiving durva in chemotherapy in BTC. So our OS was definitely lower because a larger number of patients were gallbladder patients, and a lesser number of patients we could actually use the second line targeted therapies. But yes, the OS was numerically better in the cholangio group when compared to the GP. We don't know the answer for that. What is important is that this move of actually advocating IO in the first line setting in a very a cancer which doesn't have much options to offer, rather a very poor zone, is something which is welcome. And we look forward to actually improvise upon adding IO in the first line setting, like you can use IO plus IO combinations, or how will the IO be combined with an anti-VEGF, like how we do it in hepatocellular carcinomas, or rather identifying a particular predictive biomarker or a biomarker which we can offer or select and tease out these populations and then tailor their treatments accordingly. Thank you very much.
Thank you, Dr. Avinash. Excellent. It was a very crisp and message, I think, conveyed to the audience. Now, I am a gastroenterologist. Very few basic queries. Do you need me to put stents? I'll talk more on biliary tract rather than GP. I'll talk about bile duct and others. Do you need me to put stents? How much bilirubin do you want to bring it down so that you can start your turban? And the other thing is that, do you see or do you feel that your patient may develop a acute liver failure or a emergent colitis?
So I would be comfortable if you guys could actually drain 50% of the liver. So we just have to be patient, because if the bilirubin starts declining and the features of cholangitis have subsided, then I'll be more comfortable, because the start of the decline is what I actually look for. And there are certain situations where we are pushed, to actually start the treatment even when the bilirubin is close to around 5 milligrams per day. But if the sepsis and the cholangitis resolves, then yes. Because what we are looking at here is that sometimes we might have to tweak the chemotherapy by starting a single agent gemcitabine alone, because that is hepatosafe, and then add the platinum. And we try to avoid and rather not use oxaliplatin because of its propensity to cause more liver injury.
That is, you start gemcitabine earlier than you.
No, I mean to say gem plus durva. So I'm talking about the chemotherapy backbone.
You see, advanced gallbladder cancer is a dismal situation, I agree. And in your study you said that 76% has progressive disease. On the background of this study, if you have patient of advanced gallbladder having 76% having a progressive disease in spite of the immunotherapy, do you think in Indian setting with this cost of therapy should be a wise choice for advanced gallbladder cancers?
Yes, so if you ask of me, there is nothing else to offer. So The other important feature why the GBs differed, or if you look at the subset of the populations which actually had the best benefit with adding IO, was the intrahepatic cholangios. Now, as I told you, the intrahepatic, the perihilar or the extrahepatic, and the GB, though they are anatomically very close to each other, they are heterogeneous in molecular wise. I have not put the data of how Durva did in various molecular subtypes of the BTCs, and it is important to note that the best outcomes were with the intrahepatic cholangios and the worst was with GB. And if you look at the real world data, we also had the same similar topography. So our GBs did not do well at all. We don't know exactly what the reason for that is. There is some, there is some concept, or it's again a hypothesis, which people say that probably in GBs, in Indian population, we close to have around 15 to 20% which are HER2 positive. And again, this is different between the Western versus Western Asian versus the East Asians. So understanding this heterogeneity or the epidemiology is something which we are at this stage. Probably we might have to use something else in addition to the IO. That is where the learning curve is. Is IO just alone enough, or IO plus chemotherapy alone enough, or should we add IO plus a targeted therapy, like say IO plus an anti-VEGF, because GB is something which is driven by the VEGF pathway. So not just IO, but maybe IO plus a VEGF inhibitor. So the trials on the way, maybe down the line we will find an answer for that. But I agree with you totally, but this is, GB is one of the most difficult, an advanced GB is one of the most difficult things to have. Fortunately, no, sir. Fortunately, no. As I told you, it's just like the clinical judgment, it decides everything, actually speaking.
Any further questions? We are going late, and the organizer have requested to really. Thank you so much. We have so much learning from this. I'm really grateful to Medica Oncology and as you also to call us and share this session. We learn so many things on a Sunday. And really, Medica, I think we'll go ahead with the class.
One moment, sir. This is the end of session 1. So I would like to felicitate everybody. So you would do it actually. So everybody who was there. So we'd like to call upon everybody one by one, and so both of you would felicitate them. Okay. So Dr. Swapnil, are you here? Okay. Dr. Suresh, Dr. Amar, Shetty sir, are you here? You left. Shubhida. Dr. Swaralika? Okay, so we'll keep her. Okay. Dr. Puneet? Oh, he left, I think. Dr. Niladri? Sir? Tapesh, sir? Avinash, sir? Avinish. And Avinash, sir. I think I've covered everybody. And ML Shah, sir, could I request you to please felicitate our chairpersons? Dr. Dipti Das, Professor Radiotherapy, MCH Kolkata. Dr. M.S. Shah, Professor and ex-HOD Department of General Surgery, SSKM, currently at Vivekananda Institute of Medical Science. And the moderator of the session, Dr. Conclave, is a medical oncologist at Tata Medical Center, Calcutta. I request the panelists to join us on the stage. Dr. Avnish Saklani, Professor and Head of Colorectal Services, Department of Surgical Oncology, TMH, Mumbai. Dr. Vivek, Consultant Surgical Oncologist, SSO, Mumbai. Dr. Swapnil Patel, Associate Professor, Surgical Oncology, Varanasi. Dr. Mikko Das, Consultant GI and Hematology Services, Department of Surgical Oncology, TMC, Kolkata. Dr. Akshay, Senior Medical Oncologist, Sunrise Oncology Center, Mumbai. Dr. M.D. Chandrakant, Senior Medical Oncologist, Narayana Hospital, Kolkata. Dr. Avinash, Senior Consultant Medical Oncology, AIG, Hyderabad. Dr. Avinu, Associate Consultant, Department of Onco-Anesthesia, Perioperative Care at Wake Medica Cancer Center. The topic of the panel discussion will be role of CRS and HIPEC in peritoneal metastasis and updates in systemic therapy. Over to Dr. Shobhita.
Good morning. Thank you, organizers. Thank you, Dr. Sudeep, for inviting. And congratulations to the Medica team for opening a new cancer hospital first time. So today's topic is advanced colon cancer, role of CRS HIPEC. I have my medical oncologist friend, I have surgeons, and Dr. Saklani said I met you in the CRS HIPEC in Tata Medical Center where you were asking me questions. No, I'm not going to ask you a question because I have passed a controversial bill which you did not like at that time, but again I will ask you in the other way around. No, sir. And we have on anesthesia also. I don't have much questions for you, don't worry. Maybe for the surgeons, when the surgeon will say something, then I will ask you the question. So we'll start with the case, 48-year-old female, diagnosed case of right colon cancer. She was operated in 2017, till 2019 it will be, and she received completed treatment in 2020. On periodic follow-up, she presented with a raised CA in 2021. And CA is 12 units, so I will ask first with my colleague, Dr. Viproda from Tata Medical Center, so what will you do next?
As a routine follow-up, as a routine follow-up, we'll do a proper CT scan, CT thorax, whole abdomen, and we'll see the possible site of recurrence.
So this is the CT scan. We showed a deposit in the mesentery around before in front of the S1 vertebra. There is no other disease elsewhere.
To me, it looks like a solitary peritoneal deposit, means peritoneal recurrence. It does not look like a node. It's typical of a solitary peritoneal deposit with buckling of surrounding tissue. So, and if there is no other tissue, no other disease elsewhere, I definitely consider it to be this is a treatable disease.
So, Dr. Swapnil Patel, my question is, will you do a colonoscopy for this patient or you just go for surgery?
If I am not mistaken, the
you do any other tumor markers, or you are happy with only CA? So now next question will be to Dr. Vivek. So this patient is a curative, is a solitary omental deposit. So what would be your surgical plan for this patient?
The surgical plan would include staging laparoscopy first to ensure that this is the only site of metastasis, because the sensitivity of CT scan can be as low as 10 to 30% if it's less than 1 centimeter size. So I'll include a staging laparoscopy. If there is no match elsewhere, and this is the isolated met, it is surgically resectable, and I'll go ahead with the resection.
Sir, will you go for a CRS high pick here, or just taking out the omental meds?
May I see the chronology of events, because I think on the scan it's like 2017 surgery.
So it is 2019, sir. She recovered within 1 year of the adjuvant therapy.
But this looks like an aggressive thing. It's into tumor, so there is 20% chance of having pericarditis disease at the same time. I think what Vivek has said, we do a staging laparoscopy. Because this is colon, there's a good chance that it may be MSI high as well. So I normally give surgery as a reserve, unlike all other surgeons. So I get an MSI testing there.
Okay.
If it comes, then you can think of immunotherapy and things like that. But recurrent tricolons are quite there. So we don't know whether we should give neoadjuvant chemotherapy after staging laparoscopy or go for surgery straight with the Kairos. The data is still not out for Kairos 6, but the progression rates were low. But in our practice itself, we give a lot of neoadjuvant chemotherapy, progression rate is high. So for this, if the PCI is low, I would discuss with the option to give 4 cycles of chemotherapy and going for surgery if MSI seems to be stable. Or to go ahead with this one for limited use. You get a lot of recurrent tricolon, 3 to 8
So I think, sir, you are one person who has told that you will go give chemo and then go for the surgery.
I would discuss with the patient, because at the end of the day, data shows it's okay.
Anyone wants to contradict him?
I think the plan seems right, because many attempts are not always. Recurrent tricolon disease with peritoneal disease is not a good disease to treat surgically, depending upon findings of staging laparoscopy and the PCI which we have to deal with.
Okay, so Asher, molecular studies was saying, so what molecular studies you will do at this level?
Yeah, so basically, at this level, I would like to just get MSI, basically, then the BRAF, ALRAS, and HER2.
What you will do now? Suppose this patient is MSI high. You have in your ability the surgeon feels, not like Professor Sakrani sir. Sakrani sir is very, very pro-med of, I must say. No, but at least as of today, as of the last 5 minutes, the surgeon, my colleague, I tell you my answer. My colleague Dr. Victoria, she will say go for surgery, CRS high. This is MSI high, money is not an issue. Will you just give immunotherapy to this patient?
If it is MSI high, I will offer, but I will also think like what Sir said, I will simply explain that in this era of immunotherapy, the benefits or how it will pair up with the CRS and hypo is not exactly. So I would put my bet for chemotherapy.
Will you give targeted therapy to this patient? Like if supplements are referred to you for systemic chemotherapy, will you give any targeted therapy in a neoadjuvant setting, or will you just give standard systemic KPOS or FOLFOS?
So I think to begin with, it was a right-sided tumor.
Yeah.
So, right-sided tumor more like, BEV is, cetuximab basically, though it is the ALRAS type. So, now we do have pathological classification, but still we are not using it as a clinical practice. So I will just get guided by whatever the molecular marker suggests. MSI high, again, I will be more inclined towards immuno, if at all it is there. Though we can always have, but the immuno plus chemo, if somebody wanted to use, very high disease burden is there, I really wanted to get it under control. And surgery is package surgery, I will just hold on the baby for time being.
Just in addition to this particular thing, if as result is not yet outside. So if this patient is the only site of recurrence, whether if you can completely remove the tumor, whether you can give a chemotherapy life to this patient.
anyone wants to take that question?
So, yeah. So, see, the thing is that whenever we are treating these diseases, there is no defined role of adjuvant therapy when you have done metastatic therapy. Actually, there is no role. But considering this was a systemic disease.
But recently there was a publication where it showed that for liver metastasis, after metastectomy, there is a role of adjuvant.
Adjuvant, there is liver mets for peritoneal mets. So peritoneal mets, if you are doing like CRS, IPAC kind of thing, we are really not sure. And that is what is Dr. Avinash was saying some time back, CRS, IPAC and immunotherapy. Now how we are going to deal with this really is going to be a bigger question. But see, essentially we have to think that this is a systemic disease. Only thing here, we are just seeing this one med. So probably there will be some micromeds will be hovering around. And maybe, I think, we'll go by Dr. Nayan Saklani's approach, give something before and then, we'll be done.
Okay. Well, our EIMD surgeons were very loud mouth. So they said that they wanted to do CRS IPAC. So I want to involve you. So what are the precautions from your point of view, what you're going to tell the surgeons or how you're going to assess for a patient who is going for a CRS IPAC?
So rehabilitation is a very important part, especially team effort. So proper communication with the surgeon and anesthetist and also medical oncology person is very important. Also the ICD, the periodic management. Rehabilitation part, the nutritional part is very important in physiotherapy, and also psychological part is also important. Counseling and everything needs to be done. For the assessment environment, for the physiotherapy part, the person needs to have regular incentive pattern to increase her catheter tolerance and all, so that perioperatively the ICU stay and everything can be decreased. And if at all any other nutritional optimization needs to be done, it's very important. I think the albumin levels and all needs to be assessed.
So as I said, the patient, the surgeon said no, the surgeons are the strong force because they conducted EIMD, their team only sends the mail to us. So that's why they forced us that the patient should undergo CRS IPAC. So I will ask, I will come to you later, sir. Dr. Shopney, what is your experience with the CRS IPAC? How is mortality?
Initially, I think the team is experienced, the mortality or morbidity for CRS IPAC is the same as for any grade 6 GI-HCV surgery, be it liver surgery or be it liver section. And the entire team which is important. And specifically for the CRS which goes on for longer amount of time, the intraoperative management of the oncologist is very important. And because that is what decides, especially in the high volume PMPs and all, if the patient is stable, then you will be able to go ahead with high-tech or not.
Dr. Swapnil, anything different or you agree with him?
Yeah, I agree with Swapnil with regard to that, because I think the one definitive paper we have is from Italy, from Dr. Kusumura, where they showed that the plateaus of morbidity come after 110 to 130 patients. And the plateau in the mortality comes from 120 to 140 patients. So I think that number of patients when you're operating in a center, then we get the results that you mentioned, that we have only, which are equal to grade 6 HPV surgery and this more. So always these surgeries need to be performed in an experienced center with an experienced team.
Sir, I have.
Outcomes improve with experience, and experience comes from bad judgment. So I think once you've done your cases, you at least know when. So earlier case of CRS IPAC, you do a lot more surgery and find out that there's not too late bleeding.
Sir, now I just want to ask you, the two CRS IPAC trials, the one was in 2003 and recently the PRODIS, it failed. Just want to ask you, why the surgeons could, why the CRS IPAC data could not show a proper OS benefit or a DFS benefit data? It's not from a medical point of view.
No, I look at this bottle of water, you're looking at it half.
Yes, sir, half glass half.
So actually, if you look at survival potential metastasis of 12 months or so.
True,
But
sir.
at the end of this one, now, 42 months or something, that's a success. If you need a trial for medical oncology and you get 1.5 month benefit.
Sir, 10 days, 7 days benefit, we got the approval.
Actually, the only thing with the trial was a bit flawed.
of analysis benefit and try to say that this for this group of patient, the patient will.
But I think overall, I think the enthusiasm of colorectal treatment has gone down because I think the case selection is not right. But I think if you select a patient with a BCLS and protein and you have experience, then the mobility is a sort of thing. Because once they understand it, and then with the outcomes improve, and we will have to see that. So we offer them more packages in that way.
So you are using some micronizing and toxicology.
We are not doing harm.
And you are using a different chemotherapy protocol? I think we are also using the micronizing toxicology. And
only thing I would addition on this, because if you attend any conference, everything is and a lot of discussion has happened. The most important thing what Sarah had mentioned, apart from that, I think that the protein cell was absolutely overestimation of it. From 30 months, their expectation was probably high peak is going to be more than 48 months, which was absolutely an overestimation. From where they come that 18 months benefit, that was a real question. How come it's not a magic, it's not so that is even from expectation was 48 months, but we got around 42 months. So which was not bad at all.
Okay, just asking, like suppose a patient undergoes CRS hypex, will you ever make the patient undergo a CRS hypex again? He or she because of 2 years, or if a patient has a solitary liver met with a mental disease. Do you, sorry.
CRS hypex, generally we repeat the CRS as complete cytoreduction, get a CC0, but generally we won't repeat the hypex.
And does the right sided and left sided, because we have suddenly found in the medical oncology that the right side, left side behaves differently. So do you think that will also make an impact in your decision for CRS hypex?
So as Sir mentioned, we had when I was doing my fellowship in Tata, there was an extensive review of the data of right hemicolectomies. Even doing the redo right hemicolectomy used to be challenging, especially when you have a recurrence that is there in the para-aortic or in the root of the mesentery. So if there is a recurrence in the left colon, yes, you are more proactive in going into the surgery. But right colon, like Sir mentioned, we are a little conservative.
So the patient underwent the CRS hypex. The PCA score was 3. The chemotherapeutic regime which was used in our institute by the surgeon was micronizing C and doxorubicin. The biopsy report, the serosal deposit is involved by the adenocarcinoma. Akshay, will you give adjuvant chemo to this patient? The surgeon referred to it.
So there is no data to suggest, the adjuvant chemotherapy will help. But I will discuss with the patient, and even at this juncture, I would like to get again the molecular testing done. Anyway, he has underwent CRS hypex, then.
Okay, suppose a patient is a molecular RAS-Y, MSI stable. Will you give adjuvant targeted therapy to this patient?
No.
Oh. Then just asking, then why you want to do it?
No, if MSI comes high, then maybe.
Adjuvant immunotherapy, I think.
No, adjuvant immunotherapy is still not there. You have data for neoadjuvant immunotherapy, but again, there is a first line locally advanced CA colon. The data which is there, the data of Pembro is there. But now, like that's what I'm saying, we will have to explain the patient. There is no data to suggest, but we can extrapolate maybe from the other sides. Anyway, you have done such a high, and you said money is no issue. So I think it's worthwhile to see this. But as per recommendation, I really don't know.
Dr. Avinash, will you give adjuvant chemo to this patient?
I think one of the lessons that we learned from all the CRS and the hypex studies, irrespective of whatever the flaws in the studies, was that systemic chemotherapy had to be given, and the benefits were clear with systemic chemotherapy. But that is a matter of discussion, like what Dr. Ashish said, is that we will not be able to guess or give them an estimate of how the benefit would be. But we will definitely offer it to the patient, and then yes. And as of immunotherapy and targeted therapy is concerned, probably a no.
I think we have, because we as an institute, we thought that we'll give chemotherapy. Because the patient has a pre-existing peripheral neuropathy, we just gave capsulogen. The patient is on follow, but last week only because this was taken in the NEP, patient has developed a soft tissue thickening at the right ureter, in the ureter, but the CA is normal, so the surgeons are now, the GI surgeon is passing the ball to the neurosurgeon to see what they are going to do, whether it's a new malignancy or not. But anyway, we will come. Now
do you feel really like maintenance is just like prayers you are doing?
It's like we thought that
not relax.
No, it's like we thought that cancer is a systemic disease. So some point of chemotherapy is like will give some prevent some distant recurrence. So that's why we have given. Obviously, as you said, there is no strong clear-cut data. At least for the liver metastasis, there is a data, but this. Now I will involve my surgeons. Now I will just take 5-10 minutes from you guys. So in a patient with a metastatic colon cancer, like anything else you want to do molecular studies, or this is you are happy with this?
Friend, this is good.
Just suppose the patient is a RAS wild type, but amplified. The patient has progressed on peroxisome. Will you give the patient cetuximab or panitumumab, or you will just say no, you won't respond to cetuximab or pani because you have a HER2 amplification is there?
So, I think that, like the HER2, the way we look at other places is not similarly. Only thing is, yes, it predicts a poor response to EGFR therapy, but still, what else to offer, like TDX when the patient is going to be there. So, I think then I will give still a chance with the anti-EGFR.
Dr. Avinash, for which patients you will give mono treatment? Oh, I think I'm missing that.
I think.
Just 5 minutes.
Yeah, so
I think you take the blue and the visiting right side, and Dr. Asha will take the other side, and that's my last slide.
So I think, monotherapy would be definitely down the line with third line setting, or especially with regorafenib. And yes, so yeah, obviously, so they do not fit into the really fit population, and immunotherapy in MSI high cancers. So that these are the two situations which I can think of using monotherapy as such. Triplet, yes. I think in an oligometastatic like where we have a liver-only resectable disease, there is one where we can add an extremely fit patient, PS01, so that is where I try to use a triplet.
So what's muscle involvement if the surgeon says that he cannot operate as of today because the chance of margin is there, that the patient is fit? Will you consider doing a triplet?
If the patient is fit, yes.
And Dr. Ashad, the last thing.
Yeah, just to add with either triplet or doublet with targeted therapy. So both of this will be like equivalent. So if somebody wanted to use. So the things targeted therapy for anti-BRAF, no, not upfront. Maybe third line or something like that. First two lines.
The second line results are out.
Yeah. So the thing is a targeted therapy again for anti-HER2. Again, I will say I will first go by standard. Use BEV. You can still save aflibercept. You have other options also with that. And then maybe anti-HER2 if the patient is going for TDX. Immunotherapy, yes, definitely. Yeah, so especially the right-sided tumors, the immunotherapy, if you see MSI high or MMR deficiency, I think these are the tumors you should be looking for. If you're going double NIPO-EP, again that is great. Or maybe if the disease burden is very high, I might combine it with the chemotherapy maybe for the initial part of it, and then salvage therapy, regorafenib. I think regorafenib is something which is very difficult drug to handle. Actually, I don't know.
Some of us have seen patient tolerance also.
Yeah, and I don't know, but the best response has always been the stable disease, which I got. So I think regorafenib is down the line.
Surgeons can compare with the 1.5 such a toxic drug. We are saying we have a therapy in our armatorium.
Yeah, but I mean, essentially, I hardly remember any patient of CA program. Task 102 again third line. So
this is task 102 with peroxisome, the sunshine.
Yeah, so that's what I'm saying. So in the third line, definitely I've used.
Will you use it in the second line or a patient who is not that fit?
Yeah, so the thing is that task 102, but if you essentially look at it, the original dose of task 102 which was recommended is hardly ever tolerable. I burned my fingers almost like patient had AML like toxicity. First time antifungal I've used in task 102. But now with the experience, the new scheduling which is there, 5 days every 40 days. So that is something which is easily tolerable. So I think that is most important. Maybe the borderline, especially cardiac abnormalities, is there where you don't want to give 5 to 10. I think is a task 102 plus bed will be a good choice.
I think that's my luck. This one we already have discussed, so thank you. If there are any questions to the panelists, they can ask.
I think just one comment. I think that is a statement for Batman. They're all looking for you, Batman. Hope is what they're looking for. So that is what we're doing.
True, sir.
Yeah. It's a good discussion on a difficult case. Yes, adjuvant and UR20 they are not high-tech and CRS is a evolving situation or in selected cases to consider giving the patient another day of high-tech and CRS.
Thank you, panelists.
What if they run away? तुम्हें छोड़ेगा? One. Felicitate? For felicitation or for the next session? We'll go on to the next session then. Okay, so moving on to the next panel discussion, borderline resectable pancreatic cancers. Moderator will be Dr. Manish Bhandari, Professor GI Veterinary Services, Department of Surgical Oncology, TMH Mumbai. The panelists for the top panel discussion will be Dr. Shekhar Gupta, HOD Surgical Oncology, Apollo Hospital, Calcutta. Gangopadhyay, Consultant Medical Oncology, Apollo Hospital, Kolkata. Dr. Rajiv Jaina, Consultant Medical Oncology, NCRI, Kolkata. Dr. Anupam Datta, Consultant Radiation Oncologist, NCRI, Kolkata. Dr. Shomen Das, he's not come, from Medica Hospital. I think he's not here today. Over to you, sir.
Good afternoon, everyone. Good afternoon to the panelists. Thank you, Arindam, and the organizing team. I congratulate for this excellent conference. Today, I'm going to moderate a session on borderline resectable pancreatic cancer. So, we all know that pancreatic cancer, we clinically define them into categories as resectable disease, borderline resectable, locally advanced, and of course metastatic disease is another spectrum. Majority of the patients do fall into locally advanced and metastatic disease, so the option or the curative option is limited in those situations. But what has happened in the past few years is that the borderline resectable disease, the scope has got expanded with newer and newer definitions. I think more diseases which were defined before as locally advanced are now becoming defined as borderline resectable, where the treatment, the curative options are still open. So if we evaluate the number of definitions, now my question to Dr. Shekhar would be, to begin with, is there are several definitions available, which one is the best, and what do you follow?
See, without getting embroiled in various definitions of borderline resectable pancreatic cancer, basically, a tumor which you feel is not going to, you are not going to get a resection with negative margins, with upfront surgery, as per the expertise available in your center. So there are three criteria. One is the anatomical criteria of the tumor itself. Second is very important to the patient criteria, whether the patient can tolerate, that particular patient can tolerate that scale of surgery if you are supposing planning a vascular resection upfront. And of course, the potential for systemic disease in that patient. Purely going by anatomical criteria, if you take, it's basically down to the artery and the vein. Yeah, so basically if we're talking about, are we talking about body and head both, or are we talking about head of pancreas only? Head pancreas.
So as a whole.
As a whole. So basically, if you take the artery itself, abutment of the common hepatic artery, where you can get by with the dissection of a segment of the common hepatic artery, less than 180-degree encasement of the superior mesenteric artery, or an involvement of the vein, SMVPV, which can be more than 180-degree. Basically, when you feel that the segment of involvement, you can get away with a resection and reanastomosis, or maybe a vein graft. So it's the. But if you feel that you can get away with an R0 resection with a vascular resection, that is a borderline resection. All three. Common hepatic artery also, abutment, not encasement, abutment of IVC, segmental involvement of SMVPV, less than 180-degree SMA, first jejunal branch. So segment of common hepatic artery, borderline resection.
Right. So I totally agree with what you said. Despite the definitions, what we have to gauge in the preoperative workup is that if margin positive risk is high versus low, that is very important. But beyond that, we also need, as you said, the anatomical definitions, because some guide, some standardization also has to be there. Otherwise, it's going to be a problem.
Absolutely, it can't be center-specific.
So, Nawaz, again following on the same lines, regarding the anatomical classifications, there are at least 4 of them. What is the preferred one? over?
Yeah, so largely I agree with sir as to, instead of getting into the technicalities, we all need to, so give a broad definition. But we know that to get more data, we have to have uniform definitions around the globe so that there is uniformity when you do studies. So there are a lot of definitions that have been given by different groups. So the one which we try to stick to is what the NCCN has endorsed.
Right.
It's also been endorsed by the ISTPS group, the International Study Group of Pancreas Surgery. So lastly, what sir mentioned. So for head of pancreas, the vein criteria is a reconstructable superior incentive vein or portal vein involvement. The keyword being reconstructable. You should have suitable vein above and below, which will enable you to do good anastomosis. The artery criteria is an abutment of SMA less than 180 degree, or a short segment involvement of GDA with common hepatic artery, which is again reconstructed. So this is the definition we stick to now. When you come to the body, you also include 180 degree abutment of celiac axis as well. So this is the definition.
GDA has to be free in that.
Right.
If you are taking celiac axis involvement in body, the GDA has to be free, so that will be maybe possible.
Right. Yeah, so what is important to know is that we have definitions which are separate for head pancreas, separate for body tail. NCCN or the MD Anderson definition is the most commonly followed world over. But essentially for clinical practice, as Dr. Shekhar said, we have to judge whether it's going to be a margin positive or margin negative, and then you plan accordingly. Also, very rightly as he mentioned, it's anatomical, biochemical, and conditional. All three are important. Just anatomical topographic is not good. But even if there are definitions, this is what happens in real world. This is a very recent paper. Borderline resectable disease, which was already defined, was reviewed by experts world over, more than about 96 clinicians, evaluated the CT scan of patients who were, and radiologists also, very experienced senior people, and you see the heterogeneity in their reporting in terms of considering it as either resectable or a borderline resectable disease. There is very low level of agreement, even with experienced surgeons, and lack of consistency in reporting. So this is a challenge that we will face and we will continue to face as long as we try to simplify the definition of borderline resectability rather than sticking into those various degrees of involvements that we have. Right, so coming to the case, this is a 45-year-old gentleman who presented with obstructive jaundice, underwent stenting. First a plastic stent was placed, later changed to metal stent, which is a common scenario which we see. The triphasic CT scan showed an uncinate mass with SMA and SNV abutment. That's a loose radiology report. Unfortunately, we don't have the radiologist today with us, but I'm sure you guys can take those questions as well. An ultrasound-guided, EUS-guided FNAC was performed, which was adenocarcinoma, and the tumor marker was 1650. I don't have a full image for this case, but this is what it is. This is the arterial phase. That's how you see the vein is not getting opacified fully. It's not because of any thrombus, but it's because it's an arterial phase. So, would you like to comment on this CT scan? And
now on the image on the right hand side, we see 180 degree, less than 180 degree abutment of the SMV, and the superior mesenteric artery and the first general branch are also very, very close for comfort, although there is no encasement point less than 180 degree more than. SMA on the right hand side image is okay. Left hand side image looks really bad. I mean, to me it looks more than 180 degree encasement of the vein. This is definitely not, by my book, he's 45. This is definitely borderline resectable. CA 19.9 is very high. So I would go with systemic therapy takes priority in this patient. I would not resect this patient after systemic therapy.
Okay. And also a point on, as you said, CA 19.9 is high. But often what we also face in clinics is there is obstructive jaundice also accompanying. So how do you take these CA19-9 levels into the clinical context, whether this is disease related or whether this is obstruction related, or would you always consider the value which is after the jaundice has normalized, after a stent has been placed? Is that
after the bilirubin has normalized, they will repeat the CA19.9.
right?
But systemic therapy,
Okay.
neoadjuvant therapy.
Okay. So another question was in this same case, an US guided FNAC has already been done. And yes, as Dr. Shekhar said, it's a borderline resectable disease. It looks difficult to achieve R0 on upfront surgery. Anyway, it's a borderline resectable, whether to give any other therapy or no, we will come to that. But when we want a tissue diagnosis, is US guided better or CT guided is better? Or what is the practice?
There's no clear answer exactly, but it's a US guidance is better than CT guidance because there is a theoretical possibility of seeking angiogram or for cancer dominant. So if you have the option, if you have the expertise, always go for US guided labs.
Okay. Okay. So Dr. Shekhar has already said.
Our institution practice is to attempt US guided FNAC or co-vaccine first, and many a time it's inconclusive. Then to consult the radiologist, how easy will the access be for a CT guided biopsy? If this is okay, no, he has a good access, then to go for a CT guided one. If not, to repeat the US guided biopsy.
Right. So we are at the diagnosis of borderline resectable disease, and I think both the surgeons are saying no surgery.
So would we consider doing staging laparoscopy instead? Because you know that the CA99 is high. Of course, we have to take into consideration because the patient has cholangitis. But would CA19 be that high just because of cholangitis? So would you consider doing a staging lab instead?
Yes. Yes. So it is advocated that whenever the CA19 is higher than 500, it's ideal that a staging lab is performed to rule out unpocket metastatic peritoneal disease so that you don't over-treat them and treatments are better planned later. So that's a very good point that we must consider as a part of staging workup, not only a triphasic CT scan which is done, but also in some of these cases with high CA19-9, a staging laparoscopy should also be considered. So, no surgery, but from medical oncology and radiation oncology, I want to ask you which approach would you like to prefer in this case? Will it be only NACT or should it be chemotherapy with radiation?
So neoadjuvant chemotherapy. So this is CA pancreas is mostly systemic disease, tends to fail systemically, and addressing micrometastasis is important, and also to understand the disease biology. The initial 4 months of chemotherapy is important because if it is going to progress after 4 months, mostly that candidate was anyway not for resection. So how much radiation adds in the neoadjuvant setting is very debatable. So mostly neoadjuvant chemotherapy is with patient mostly for 4 months.
I'm sure Dr. Anupam will add his voice.
No, yeah, I would like to agree with Devina in certain points that with neoadjuvant chemo, we also reduce the post-operative morbidity because we have a better resection added and recovery is better and adjuvant treatment tolerability is also better. But having said that, if we give only in the CTRT, I don't expect good results because the trials they already have mandated that, the most curative treatment for borderline pancreas is an R0 resection flat. So on that, if we give only NSCTRT, that's not going to benefit. We have to give NSC followed by downstaging.
Okay. So yes, evidence-wise, if we see, there is hardly any evidence, which is level 1 evidence for neoadjuvant approach in borderline resectable disease. The only trial probably which is there is Biobank trial, but it included resectable and borderline resectable. In the other 2 studies, which is the SPAC5 and the Alliance trial, both have been favoring modified FOLFIRINOX as a regimen for neoadjuvant approach, and somehow the radiation has not come to the forefront in terms of, although its role cannot be completely ignored just now, but the data is not so much in favor at present. But the results of the meta-analysis also show that neoadjuvant approach, whether chemo or with radiation, is also good for borderline receptacles. Although no level 1 evidence, but the acceptability of a neoadjuvant approach has come in the past decade for borderline resectable disease. But there are still some questions which we are yet to answer. One is of course radiation. The other one is if chemo, which chemo and how long. So, from Medica Oncology, both of you.
So, neoadjuvant chemotherapy with gem-nab-paclitaxel or modified FOLFIRINOX are both acceptable regimes. What I have practiced because my patients because of their poor GC. So usually I have given gem-nab-paclitaxel and very few patients with modified FOLFIRINOX have usually it should be tried for 2 to 3 months at least to and get a reassessment if whether it is responding or not.
Okay. Any difference?
So there's no head-to-head data which can tell which is superior regimen. So nab-paclitaxel, no RCT against FOLFIRINOX. But FOLFIRINOX in its trial have produced superior response rates, and if a patient is fit enough to get it, then definitely FOLFIRINOX is the way to go.
Right, absolutely true. There is no OS benefits shown in any trials, but as you rightly said, the response rates have been documented to be better with FOLFIRINOX, which is I think upwards of 30% or around 35% to 40%, which is very high for a disease which was thought to be chemo resistant. So once we do, we don't have radiologists, but once we do this neoadjuvant approach, how do we evaluate? As you said that we evaluate them in treatment. What is your preferred evaluation and what intervals?
I would go like this exam, pancreas protocol like this exam, and also tumor markers, because the tumor markers should at least stay stable, if not improvise. I mean, if it improvises scenario, it should at least stay stable. You should not have a situation where the tumor markers are rising. And as far as scan goes, you don't expect a lot of anatomical response on the CT scan. So it's supposed to have a lot of other factors. Has the patient done well with chemotherapy? Is he subjectively better? Is the C99 stable or going down? Cholangitis has been taken care of. So if there is no gross increase of disease on the CT scan, this patient mandates on examination.
Okay.
So the key is to make sure that there is no increase of disease. You're not going to really see a response on the CT scan. That's the key understanding.
So that's also a very important point that radiologically you may or may not see a response after neoadjuvant approach. And in this patient also, first initially 4 cycles of FOLFIRINOX was given, then a reassessment was done, and then additional 4 cycles were delivered. Our radiation oncologists wanted to give, but the medical oncologists at our team did not allow them to give, and they completed with 4 because there is no evidence head-to-head. And of course, modified FOLFIRINOX. The tolerance is also something that you want to look at in these patients. So I will come to some role later, but in this case, at the end of 4 cycles of FOLFIRINOX, there is some radiological response, and also there is a tumor marker response, and 8 cycles have been given, which is at least 3 to 4 months of therapy has been given. So at this point, Dr. Shekhar, what would you like to offer?
This patient has had a very good response, I think. He will probably still require a venous resection because there is less than 180 degree abutment of the SLB. And the uncinate process margin may come positive at the SMA. But there was this study, the single institution study of 122 patients where the response, they subjected all the patients to surgery, irrespective of radiological response. A lot of them they thought would turn out to be unresectable on scans. Actually turned out to be unresectable with negative margins. All patients who radiologically look operable mandate a resection post-neoadjuvant therapy. This patient I would definitely operate. And as I said, the vein would probably require a resection. I would be a little iffy about the margin on the SMA side, but definitely resection, yes.
Right. So, Nawaz, as you rightly said, there could be an issue with margin close to the SMA. Radiologically, we can't predict. But what are the techniques that we can use to get R0, particularly in situations where there is an SMA?
So this is a case where you would need some form of supplementation resection of SMA, if not a complete resection of SMA. And there was this interesting paper which spoke about the halocine and sign where they classified post-neoadjuvant chemo patients based on
But that is true, but that is more for patients with close to 180 or more than 180 degrees of SMA involvement. Here clearly we have got a response and the degree of abutment is there. There is no engagement, there is abutment. And when we have abutment, then we don't necessarily have to think in lines of major arterial dissections. But yes, to get a local R0, would you do something in addition to what you do as a standard?
an artery-first approach. So this
Right.
is where I would start with an artery-first approach.
Right.
Make sure that the artery is really free before I commit to the resection. Because before I do any steps that would make me commit to the resection. So I would not transit the pancreatic head unless I'm sure that the artery is really free. So there are different approaches to an artery-first technique. So what we would use is a combination of the posterior artery-first and the ascendant approach.
Right.
There are a lot of approaches. There are 6, and I think you described the 7, the retromesenteric approach.
Right.
6 to 7.
But the 6 are the more defined
Yes.
and the more commonly used approaches, as you rightly said. Amongst those 6 also, the right posterior and the uncinate or right medial approach is used commonly. And along with that, also what is now described as the triangle area clearance, that also gives rise to an additional R0. And in this case, as we were discussing, the vein could be involved or could not be involved, actually had claims with the tumor during surgery. So this can vary based on our radiology review versus the actual intraoperative situation, especially post-neoadjuvant therapy. And we got a very good pathology report also. It's a YPE2N0, there are 0 lymph nodes, margins are free, including the retroperitoneal or SMA margin. Now, after this,
you have to take that jejunal artery.
No, there was no need. It was what was seen in the image. Of course, this was single image. That's how it was making an impression. But it was a third part or fourth part of duodenum that was going rather than a tumor which was there. So it was a standard liver resection with triangle clearance. Good response to chemotherapy.
Role of frozen, would you say frozen on the SMB tissue here? Because the pre-NACT scan looks quite bad. And according to that scan, the SMB looks really bad.
Yeah.
So would you?
Yeah, but when you get a clear plane, there is no need for that. If you do a divestment procedure around the arteries, then the divested tissues need to be sent for frozen section. But this did not even require a proper divestment. It was a standard plane resection from this. But this kind of appearance of neurolymphatic tissue is required in these cases when it is borderline resectable. And then the chemo has also acted well, so you get a very good report of E2N0 and margin is free. So Dr. Devlina, what would you give in addition, or you would say that 8 cycles are already done, now it's enough of therapy?
Total 6 months of chemotherapy. So
Total of
once
6
already
months.
over, another 2 months.
Right. Any difference? And would you give the same chemotherapy?
Yeah, it has responded well to the chemotherapy.
That's why you would give the same chemotherapy, but you would also want to see performance status also. So quickly going to the next case, 56-year-old lady with obstructive jaundice, stented, underwent again metal stent, head pancreas mass with involvement of splenoportal confluence, SMA and SMB abutment. Again, US guided FNAC adenocarcinoma, CA19-9 of 3,500. I have a short clip of video of the CT scan of this case. You can see that the pancreas is atrophic in this case, we also had a replaced hepatic artery. The mass was again in the head pancreas location, abutting the SNV and SMA, but this was less than 180 degrees. So this is quite similar to the first case. Exactly the same, similar type of disease, similar location as got stent. CA19 also is 3,500. Borderline resectable. Of course, I have not asked this discussion because we already had this discussion on the previous scan. So this, based on this scan, it is borderline resectable. Any difference in opinion about that? It's borderline resectable. So what would be the plan again? In this case, same plan, I guess, same plan with Volcarinox. So in this case also, we went ahead with 4 cycles of Volcarinox. There is response assessment after Volcarinox. You can see that CA19-9 has remained 3,000. And you can see that there is slight increase in the SMA abutment. It has increased to 180 degrees now, which was less than 180 before. So this is an interim assessment which we often do, and this is what we have got at the end of 4 cycles. Now what would be the further plan in this type of a situation?
So here as the CA19-9 levels have come down, so there is some sort of response, definitely biochemical response. Anatomically still not resectable. I would not say this is resistance to chemotherapy, so there is no definite progression. So I would like to actually continue 2 more months of systemic chemo, the same regimen. I would not change this at this point of time and see how it is again after 2 months. And so if it is still not resectable, then after maximizing the chemotherapy, then some form of radiation to have a local control also.
But again, if the disease is not responding and the tumor marker is remaining high, would you think that there is any benefit of having radiation?
It's still high, then I don't think radiation will add much. So basically it's a systemic disease, and unless we get a good control of the we are already in terms of biomarkers, so systemic control, I don't think radiation will add much.
I feel radiation may add some benefit. Some good local control.
Well, this is the ideal scenario wherein if it has not responded to initial 4 cycles of chemotherapy, don't expect a response with the same regimen for the next 4 cycles. So this is where we have to step in at one point of time, and preferably in such cases I usually prefer an SBRT to the lesion, and in 5 fractions we'll finish it up and then we can do a response. Of course, with the curative window, because the problem is even in the response assessment, the scans that we do, the CT that we do, the pancreatic stroma is a very, very dense stroma. So sometimes in the CT itself, it's very, very hyperdense, and you have the adenous cells floating in them. So you can not always differentiate how good the response has been. Similarly, in our pathological specimens, even after doing a good dissection, the pathologist will say that the SMA margin, the surface margin is positive, despite a good dissection. So those things are dicey areas, and that is where a very, very critical call has to be taken, because if it has if it has progressed after 4 cycles of initial therapy, I don't see there is a good reason to continue with the same regimen further.
Definitely not surgery at this point. Change of regimen. Assess after 4 more cycles. If the situation remains like this, then consider adding radiation.
So So exactly the same we did. Of course, what Dr. Devrina said is also fair, that you may give some more time for Colpinox, maybe 1 or 2 cycles, but not certainly 4 more cycles or so, and then assess once. But we thought of changing it immediately at that point in time only, and that's where we changed to gemcitabine with nab-paclitaxel first. Only when we got some tumor marker response that time, then we added SPRT. Otherwise, we did not plan to add SPRT immediately because the CA19 was still 3,000. We also wanted some response in that because that indicates your systemic disease also. So once we know that there is some, the NAB is working better, then we added SPRT with 45 grades and then followed that again after another 5 cycles. As you see, the CA19 already came down after all this therapy to 500, which is good. And this is the response assessment scan at the end of all this therapy, which shows again that there is vein abutment. And you see that the SMA abutment has reduced now to less than 90 degrees after this kind of a long neoadjuvant therapy, which included Folfirinox, nab-paclitaxel, as well as SPRT. So now would you resect at this point?
The patient's general condition, the end of this system permits resection. If this patient merits deserves resection. Attempted resection. This is resectable. Again, the margin of the SMA may come first.
Right. Right. So again, the same thing. These resections. This of course is a short clip which I had.
Was it axillary or replacement?
There was a replaced right artery, and that was never involved. That was far away from tumor. So this is a short clip of the resection of the same patient. While this clip plays, what are the surgical issues or challenges that one faces after such kind of a neoadjuvant approach? Dr. Shekhar, what are the difficulties which we get during surgery?
See, after neoadjuvant chemotherapy per se, it's pretty okay. I mean, the plates are good. And apart from a little bit of desmoplastic response, fibrosis, it's not that difficult. But I have not had a great experience operating after radiation. I think 2 or 3 patients at best. But going by the experience from other organs, it shouldn't be difficult. But from what I hear from colleagues who have had a lot of experience operating after neoadjuvant chemoradiation, the plates are not as good, and they would have preferred operating without radiation. So operating after neoadjuvant chemoradiation, even if you do an artery first approach with neoadjuvant radiation, I think macroscopically it's very difficult to be sure about the margins.
That is true. Margins, we cannot be very sure unless until we have a pathology report or a frozen section evaluation. But the intraoperative difficulty, you are saying that radiation, post-radiation, there can be more problems as compared to only after neoadjuvant chemo. Which I also agree partly because more than the planes, the tissue edema or the fibrosis and the lymphatic channels, which become more non-pliable, so that the otherwise the lymphatics would get clipped easily, they can be closed easily, but the chances of post-operative thigh leak becomes higher, especially when it is post-RT. But at the same time, the responses, some of the responses that we have got after chemo plus RT are really, really good. So that it's a trade-off.
Post-op morbidity, post-radiation?
Post-radiation, as such, apart from guide leakage, there is no added morbidity unless the resections are itself. What happens is also radiations are also given for little more advanced diseases. So maybe closer to artery, there is some artery resection also accompanying in a patient where there is already radiation given. So all that can be difficult because the artery resection morbidity also comes into play. So per se, purely radiation, if we go by the data, I think I have a slide for that also. Medica, there is no problem with radiation, there is no problem with chemotherapy. We have data from the randomized trials, the SWOG trial, the PRIOPANC trial. In fact, the post-pancreatectomy, yeah.
The point I wanted to make was that Sir was telling about the fibrosis, post-heart fibrosis. Fibrosis rates are higher in long course arteries, but when we give SVRT in a shorter period of time and we straight away send the patient to you people, then I guess because the more we spend time radiating the patient, the more the fibrosis rates are higher, like in rectal cancers also. So long course artery we usually don't prefer nowadays. We only prefer short SVRTs just to buy that particular time, to crunch out that time.
Right, right. But it is not the same. Even if the data says like this, that there is no problem, there are actual technical differences that you face during surgery, and we have to take care of that when we resect. So this patient also got a good, not so good report, but yes, R0 resection was achieved. There is BNI which was positive. 5 nodes were positive. It was T2N2. Patient had received 7 cycles of nab-paclitaxel, gemcitabine with SBRT and 4 cycles of FOLFIRINOX. We give more therapy to this patient, or we say that now it's enough, all treatment is done, and now let's hope for the best. Medical oncologist. And you would wait here. Right. So we also did the same. In fact, we gave 2 more cycles of gemcitabine with nab-paclitaxel because our medical oncologist felt that let's finish with chemo only, let everything has gone well. And she was fit also. Had she not been fit for receiving this, we would have abandoned. But I agree with that approach that we stop here because enough of therapy has been given, and that is what we call as a total neoadjuvant approach in these cases. So now if we have time, let's discuss few points about surgery. For example, a lot of times what we need in borderline resectable disease is a portal vein resection. Fortunately, in both these cases, it was not required. But when we need a portal vein resection, here in this case, you see that there is a type 3 or an end-to-end portal vein resection is done. Sorry. What are the salient points? What are the precautions that one must take?
You need a good scan, study the scan, look at the length of one vein. Do you have enough vein above and below for reconstruction? And always an artificial approach. You don't want to come into this session without knowing that yeah, you can get an answer. And to keep your estimate at as less as possible.
Okay.
More or less the same. Good vascular control. Keep the ischemia time to the minimum. Keep the venous resection as the last step of the resection. So that the vascular surgeon or whoever is doing the reconstruction can immediately jump in. How to first approach?
Any particular anticoagulation that you prefer in addition to what we do it routinely?
No.
For venous resection, total venous resection?
Not intraoperatively. Preoperatively, we always give low molecular weight heparin to these patients in any case. Intraoperatively, usually we don't give any anticoagulant.
It's a hypo system. So the vascular cells are comfortable with the routine anticoagulation. So we don't have to change the anticoagulation policy because it is a hypo system. So we don't really expect much of respect to
So post-operative.
As I said, it's high flow system. Sometimes you have to interpose a graft. Then you're a little concerned. But we have persisted with the same anticoagulation policy. You haven't changed. I would like to know your graft also. I would like to know your.
So in graft situations, when a synthetic graft is used, then we have preferred the therapeutic dose of anticoagulation. Otherwise, in a standard type 2 or type 3 resection, only the standard single once a day routine dose of low molecular weight.
Yeah. And with the vein patch also same, right? Because we use a vein patch a lot of times.
Also the same. Only when a synthetic graft is being used, the risk of thrombosis
Yeah, they will
increases.
change.
And then obviously we have to. This also was discussed when we were discussing another case, that how do you judge or plan based on the preoperative CT, especially regarding arteries. This is not related to borderline resectable per se, but these are, as I said, these are all gray zones. There is so much overlap with each other. What appears locally advanced to one may appear borderline resectable to someone. So that way, how do you evaluate these scans? Do you do anything in addition to what you see as a standard image, or you ask for something else from your radiologist to evaluate in contact with the vessels better? So you are happy with the standard arterial phase coronal section CT? Do you routinely ask for? Only for borderline resectable cases. So it's a good tool to have with you, especially when you are unsure of some of these things. In standard, most of the cases, yes, you don't need to have it. And how do you plan your divestment procedures if you're planning a divestment? What are the things that you look in radiology so that you are well prepared?
As this paper mentions, so-called halogen string sign. String sign is when you see that there is distortion of the vessel. There is some narrow of the vessel. That means that the disease is probably beyond the application into the halo sign, the vessel looks in, there is surrounding tissue involvement, where you expect that the disease only till the adventitia. So this is a case where you can attempt a sub-adventitia section, whereas if there is a clear distortion of the vessel.
Sorry, Dr. Shomil is joining us. Sorry, but the surgeries are over already. The scans have been evaluated, and the patients have also got operated. But you are coming at the right point also. This is what I was asking them when we evaluate the preoperative radiology. In a case which is borderline resectable or locally advanced, obviously triphasic CT scan is the workhorse and standard of care. But when we evaluate the venous and arterial abutments, is there anything which you look for in particular, or how should you evaluate these cases? How do you report these cases? Can you just let us know a little bit in detail?
There are two terms we use. One is called abutment and one is encasement. Radiologically, abutment means up to 180 degrees circumferential involvement of the vessel, the arterial vein. Encasement is more than 180 degrees. Now, borderline resectability obviously is up to 180 degrees. More than that, we usually say it as unresectable from the radiological point of view.
Great. But from surgeon's point of view, what you said is absolutely right. And fortunately nowadays surgeons are also, at least good enough to read a little bit about the scans in these patients. But what we want to know in such cases is this patient is having an abutment or an encasement of superior mesenteric artery. We would say encasement because it's more than 180. But we want to know whether the wall of the artery is involved or not involved. Now, how
arterial wall involvement in radiology is a very dicey thing. Venous part, we can easily say that is involved because venous system, the contour will be deformed and thrombus will be there. Those are two things we say about the venous system. Arterial, we usually say, that's why we usually use the terms abutment and encasement. And usually more than 180 degrees is involved.
So is there any other way to know in radiology, not in CT scan, is MRI better to evaluate?
No, MR again will give vascular artifacts because of the flow-related artifacts. CT is the standard for preoperative assessment. And usually arterial part, if we say that 180 degrees should be the criteria, more or less, for resection or non-resection. Venous part is obviously contour deformity, teardrop, thrombosis, and obviously the extent of the thrombus, the length of the thrombus, whether it can be resected or not.
Yes.
the arteries are actually surrounded by a nice neurolymphatic tissue. So except that they are generally resistant to disease infiltration because neurolymphatic tissue generally has the hypovascular, so they don't really, let the tumor really grow there. So if you don't see a distortion of the artery, say narrowing, or if there is no disease like getting edema, I think it's still worth trying a diversion. So this is what this paper talks about, the halo sign and the string sign. If you have a string sign, if there's distortion, you might not be able to get into that plane to do a safe diversion. So you probably might have to go into the plan of an arterial dissection. If that's
so the point is, yes, absolutely right, but the point is that we don't have good enough radiological tools to convincingly tell us that artery wall is invaded or not invaded. These signs have been described, but they are also not absolute. So whenever we are going in for such surgeries, we have to always have a plan of resection as a backup. Otherwise, we cannot say that, okay, I'm going to only divest this patient. That doesn't happen because it's always intraoperative also.
Yeah, for example, the image on the right side, it's right at the origin. I would not plan a divestment also in this patient because vascular control at that region, and I would be very concerned. I would rather dissect. So also the location of the thing matters.
Location matters, but also whether artery resection or divestment should be done, even if it is technically possible, is also a matter of debate. Because there is no long-term data for showing outcomes after divestment procedures or in a larger number.
Preferably to err on the side of resection.
Agreed, but there is always a trade-off again because it's pancreatic surgery, added arterial resection, the morbidity can also be even higher if you resect an artery. So all that comes into play, and that is where the debate of resection versus divestment comes in. So one final question: when we have R1 resection after neoadjuvant chemotherapy and resection, we get an R1 at SMA. Radiation was not offered in the beginning. What's the strategy? Is it always chemoradiation or consider it as bad disease biologically and we only chemo? Opinions?
If it's an R1 resection, then adjuvant chemo or adjuvant chemo is not going to compensate for that. It's as simple as that. Such is the biology of the disease.
See, at the end of the day, 25% worldwide, across all comers, 25% of resected patients are fit enough for any kind of adjuvant, post-pancreatic resections. So then it depends pretty much on the patient's general condition, I believe.
I am saying if the patient is fit for receiving all kinds of therapy that you can offer. This is, I agree, this is a clinical reality that we can't give because of the radiations. But when we have this report of R1, but the patient is otherwise fit, would you offer radiation to this patient or would you give only chemo?
Radiation has to be offered. It has to be offered because across all sites from tip to toe, radiation, one most important indication has been margin positivity. Okay. So if margin is positive, you have to give radiation. You have to add that because otherwise you cannot address the the subclinical disease over there. But having said that, it is not going to compensate for the R1 resection.
So that's what I'm saying. Is there a strong data to show advantage of adding radiation in an R1 situation in pancreatic cancer?
No, there is no such data, but we have to offer something.
And the question comes in because we think that we have to offer, there is something there, but we have to also consider the morbidity of adding a radiation in the post-operative period. So from that sense, this again, I would say, is a matter of debate because the data has not shown advantage. And in general, at least what we do is we judge if the overall pathology report is really not so good with a lot of nodes, a lot of DNI, in addition to an R1, then we try to avoid the morbidity of adding a radiation as against if R1 is the only positive problem, but the node positivity is less. This is what we follow, but I want to know what you follow. case of borderline resectable disease, neoadjuvant approach is standard. But what we have seen in data is around 200 cases. When we give neoadjuvant approach, we have to also think, as you said, that there is 25% of patients which will not receive chemo after surgery. But there are about 40% of patients which will not come for surgery if they receive neoadjuvant chemotherapy, especially for adenomas. So that is also something which we must keep in our minds when we are accepting neoadjuvant as a standard approach for us, because patients' fitness, stenting, cholangitis, complications, yes versus no, ability to get an R0 versus no, even if it is borderline resectable. All these things I think should still come into play when decision making is done, because at the end when we compared upfront resections versus post-neoadjuvant resections, there was no difference in overall survival, and that is purely because extra dropouts from the NACT arm. Of course, those who received NACT and they got operated had the best of the survivors. So that is good, but there will be a number of patients, either we accept that that percentage will be, we lose out, there would be some biological selection, or there could be selection based on conditional factors, because the outcomes are still the same. Overall, the outcomes that we have got improved in the past few years is because of surgical techniques, because of improved chemotherapy, because of SBRT, and because of more and more use of total neoadjuvant approach that we use now in pancreatic cancer, especially in borderline resectable and locally advanced setting. So I thank all the panelists for a wonderful discussion. And before I end, I will also take this opportunity to invite you all for the APHPBA meeting in Bangalore at the end of September this year. And also later in the year, there is this annual Tata Memorial Oncosurgery Life Surgery Workshop that also I must invite all of you to come and attend. Thank you.
Request everyone to just be on stage after the photo for the city. Right. So we'll start with the presentation of this session and the previous panel. So Sandeep sir, where is it? Yes. Dr. Manish. Sir, let's take the other session. Dr. Shekhar. Dr. Nawaz. Dr. Devi. Dr. Rajiv. Dr. Anupam. Dr. Chandra. Sir, are we Dr. Chandra. Dr. Vivek Sukumar. Am I forgetting anybody? Am I forgetting anybody? Dr. Satnam? Sorry. Sultan Hazrat. And Dr. Satnam? We have our next session.
For the next session, it's a talk on does continuation of bevacizumab post-progression benefit metastatic CRCs. We will delivered by Dr. Sandeep Rangli, the Senior Consultant at Medical Oncology in TMC Kolkata.
essential for the tumor development and progression, because tumors more than 2 mm will require an independent blood supply, and obviously the VEGF pathway, the VEGF factors, they develop the tumor growth. There is a fight between the pro-angiogenic and anti-angiogenic factors, and obviously the pro-angiogenic factors wins the race, and the tumor ultimately gets a new vasculature. And with the continual tumor's growth, there is a continual VEGF expression which leads to tumor growth and ultimately leads to metastasis. And how the bevacizumab acts? Bevacizumab is a humanized monoclonal antibody which inhibits the VEGF receptor. So as it inhibits the VEGF receptor, so there is a regression of the existing tumor vasculature, inhibition of the new vascular growth, and also it inhibits the VEGF pathway, so the permeability of the leaky capillary blood vessels gets stopped, so the metastasis also gets reduced, and early and continual effect results in a maintenance of more functional, normal vasculature, potentially improved drug delivery and inhibition of the tumor growth and metastasis. So what is the difference between the anti-EGFR and anti-VEGF pathway? Anti-EGFR, we have a single agent activity, while for anti-VEGF, we do not have a minimal single agent activity in our literature. It should be given in combination with chemo, consistent increase in the response rate, and increase the chemo and the radio sensitivity. Resensitization of tumors to chemo may be irinotecan, so that's why when you give cetuximab or panitumumab, there is more data with the irinotecan data. And in combination with the chemo, there is a decrease in interstitial pressure, better delivery of the chemo and all. Now, the bevacizumab in the metastatic colorectal cancer, the first line efficacy was the ABF2107G, where with irinotecan there was an increase in the response rate, increase in the PFS. With the NO16966, with the data with Gmox or Folfox, there was again also similar increase in the response rate and the PFS and this thing. And obviously in the second line data, E3200, there was an increase in the response rate and the PFS. But obviously these patients will progress at one point of time, and so should we continue bevacizumab? So that was the main question. There were a few studies which have shown that there is evidence of maintaining bevacizumab beyond progression. One is the two registry studies. One is the first one was the BRIGHT registry, where with the patients with bevacizumab beyond progression. Total 1,953 patients. Majority of the patients received bevacizumab in the first line. They were on the physician discretion. They were either randomized to, like it was not a randomization, it was a physician decision. A group of patients did not receive any treatment. Some group received chemotherapy without bevacizumab, and some group received bevacizumab-based chemotherapy. And it was found that those who have received bevacizumab beyond progression, their median OS was better, 31.8 months. With the OS of the first line PD also was 19.2 months, but this was not statistically, cannot be statistically compared. And the Kaplan-Meier graph showed that obviously the post-progression therapy, when we give bevacizumab, the PFS is definitely better. The survival estimates is no doubt better, the OS. And again in the forest plot, it was shown that the multivariate analysis showed that bevacizumab-based BS therapy beyond progression obviously has an independent prognostic factor in terms of progression. Another is the ABIS registry, where 1,548 patients were enrolled. The unresectable metastatic colorectal cancer, the first line chemotherapy with bevacizumab. Beyond progression, again there was no randomization, no treatment, no bevacizumab-based post-therapy based progressive disease. Again, it was found that the median OS is no doubt better in the bevacizumab arm. It was 27.5 versus 18.7 months. The median survival beyond first line progression is 14.1 versus 7. And the hazard ratio is no doubt is significant. It was 0.52. The chance of death reduced by 48%. And there is obviously a survival beyond progression. There is always advantages, no doubt is shown. But however, these limitations of the analysis were patients were not randomized. It was a registry study. Actual data regarding the actual administration dates for bevacizumab and CT were not collected. There was obviously a bias as seen in any retrospective study because the patients who do better, we tend to collect them or tend to remember them. And possibility of unmeasured factors were also may be considered. So there was a randomized trial was needed, was a need of the hour. And based on this, and the background, based on this, ML18147 study was planned. The background was that the bevacizumab in combination with 5-FU-based chemo is the standard of care. VEGF is an early and persistent promoter of tumor angiogenesis. In non-randomized observational study, continuing angiogenic factors have shown benefit in some registry studies. So the phase 3 study was considered, which compared the bevacizumab with standard first-line chemotherapy, progressive disease randomized to either the chemotherapy backbone was changed and standard second-line chemotherapy or bevacizumab 2.5 mg per kg per week. And the primary endpoint was OS, secondary endpoint was PFS, overall response rate, safety. Stratification factors were first-line chemo, first-line PFS, whether they wanted to see whether it's bevacizumab resistant or not, less than or equal to 9 months or more than 9 months. Time from the bevacizumab dose and of years. And it was found the intent to treat the bevacizumab arm as a better OS. The hazard ratio was 0.81, which was 11.2 versus 9.8 months. We are happy with this. And the subgroup analysis also shown that there is most of the subgroups has a benefit when we give continued bevacizumab even beyond probation. And PFS in the intent to treat, again there was an improvement in the PFS. It was 5.7 versus 4.1 month with a hazard ratio of 0.68, which was statistically significant. And coming to the response rate, the responders were 5.4 versus 3.9%. Majority of the patients had a stable disease and disease control rate in it was high. It was 68% compared to 54%. We should remember around 22% of the patients won't respond to this therapy, so we have to tell the patients. And the summary was the bevacizumab with standard second-line chemo significantly prolongs the OS and the PFS. Findings from the subgroup analysis for OS generally consistent with the overall population. Treatment effect according to the gender appeared to be different. Our treatment-gender interaction was not statistically significant. Difference in the base response rate was not statistically significant and is not increased when continuing bevacizumab beyond progression disease. And the conclusion was the first randomized trial which prospectively investigated the impact of continuing the VEGF inhibition, and it confirms that continuing the bevacizumab has a OS and PFS benefit. This provides a new second-line treatment options and findings indicate a potential new model for treatment approaches through multiple lines, and this is currently being investigated under tumor trials. Another study they tried to see, BEAT trial. It was poster mainly, bevacizumab progression, and they also found that there is an improvement in the PFS, 6.7 months in the bevacizumab arm versus 5 months in the non-bevacizumab arm, which was again statistically significant, but the OS data was not statistically significant. And so the phase 3 trial shows that because the VEGF expression will be continuous during the tumor growth, so the rationale is that we should continue giving bevacizumab beyond progression to improve the PFS and the OS. And the ESMO guideline has also mentioned that maintaining bevacizumab in combination with second-line chemo demonstrated improvement in the primary endpoint of OS. Thank you.
stalwarts in the field, robotic surgery, sitting in my panel. We wanted to be this way so that we, budding robotic surgeons, can draw from your experience through this. So without further ado, we'll start with our panel. So just to begin, we have seen the evolution of surgery over the past decades and centuries, and every step there were improvements, there were things which made surgery more easier, less painful for the patients, and to the point that we have come to robotic surgery now with even in intuitive also we have multiple generations of robots, and more will come on the way. As such, advantages are just divided into two about advantages to the surgeon, of course, because a surgeon who is at ease during surgery will obviously have better results with his patients. So yes, it is about the vision, magnification, the endo-risk, which is a huge boon compared to laparoscopy, firefly movement scaling and ergonomics for the surgeon. Coming to the advantages of the patient, reduced post-op pain, less blood loss, early recovery, bowel function, shorter hospital stays, and aesthetic scars. Regarding chances of conversion, we have had some controversies. We'll see them. Now coming to the evidences, from all of your branches, I would like to first ask Dr. Abhay regarding how does the evidence today show for robotic in uro-oncology?
If you ask me about the oncological outcome, the evidence doesn't suggest that any robotic is better in oncological outcome compared to the open laparoscopic surgery.
Hello. Hello. Yeah. So we're talking about functional outcome, and that means the erectile function, the incontinence rates. So there are various studies, various follow-up studies that suggest with increasing expertise, with increasing level of confidence, the functional outcomes are better. Incontinence rates is better. And in robotic surgery, you can preserve the nerves, you lost bundles, and maybe you can offer a better erectile function to the patients.
I'll go to, okay, we are missing Dr. over here. So this is called robotics in the field of environmental cancer. It's a field in which it has increased, the use of robotics has increased by leaps and bounds. And this one randomized control trial which I've quoted here, which showed that there was short-term benefits were used compared to laparoscopy, although long-term, obviously, there were at least the data is still maturing in most parts in oncological outcomes, but then they're equivalent to laparoscopy. Coming to thoracic, the role in esophageectomy and lobectomies, how does the evidence show up?
So actually, just last year there was a study published on robotic lung. They have completed accrual and they have released short-term data. A trial which was conducted in Japan with 150 patients on each side, comparing robotic to VATS. They found that robotic gets more lymph nodes and the robotic has less conversions and less post-operative complications. So the initial data is good, and this was done by a team which was very good at doing VATS surgery. So they had already done probably 5,000 VATS cases already, and now this team has randomized into robotic and etc. So the long-term data is still awaited, but short-term safety appears to be good. And if they are following the same principles of VATS, I think you will always find that there is no difference. There is no randomized trial in thoracic for esophagus or for lung where they have done robotic versus open, and I think it will never happen.
Next, sir. For colorectal cancers.
I think most of the trials are done probably in the evolution phase. In the rollout trial which had come out actually, had come and people had done only about 20 or 50 robotic surgeries, and they compared with laparoscopy with people who must have done 500. And they didn't find a difference in outcomes in terms of oncological outcomes or thing. But there was some group benefit in male patients for mid and low rectal cancer sort of thing, or in obese patients. So obviously, in India we have low BMI patients, and conversely for laparoscopies there, so may not be there. But if you look at the recent data, the real trial which has come out from China, who are very good laparoscopic surgeons, and they seem to have put outcomes for robotic for almost everything. Conversions are very low, but less blood loss, more for any outcomes that you want to look out for. So I think if you look at recent data, it was okay, it was comparable. So for me, we do a lot of laparoscopic things. So anyone who has adverse features for laparoscopy, like obese patient and mid-rectal cancer, probably it's comfortable. We also work in tertiary institutes, so we have a very good team for laparoscopy. Cameraman and assistant. Corporate you may not have that. So if you don't have a good team for cameraman, the robot itself will control the camera and the learning curve is definitely lower for robotic as well. So based on all that thing, I think robot is a place. If you look like a place in UK, they follow guidelines for this, and all the data for rollout trial not show any evidence for this. But they look at hospital itself, conversions, learning curve and the procedures. And especially in terms of COVID time, we brought out study data, MIS with robotic was done, and it's unbelievable. In UK with no real data coming out, despite now they're changing over to robotic, and some centers like Colchester, which is a center of excellence in laparoscopy, are changing over to 5 robots as well. So I think it is getting to be standard of care because they are really good technology. So I think you have to adopt it.
You almost made my job easier by answering some of the other questions also. So, Manish sir, coming to hepatopancreatic biliary cancers, it's even a yet more nascent stage, I would say, compared to colorectal. But how do you see the evidence still now?
So certainly, as compared to colorectal urology, for HPV it is much less, the evidence is much less. Within HPV it is more for liver resections. That evidence is there, and already laparoscopic liver resections have been well established, well standardized, even now are recommended in selected cases for major hepatectomies. Initial recommendation was only for segment 2, 3 lateral resections, but now also for major resections, laparoscopy has come in, and with robot, the resection at the Purna area is easier compared to laparoscopy. The transaction part of the liver still remains a challenge, but there are good techniques available with robotic, the bipolar and monopolar, with application of Pringle. The major hepatectomies are also very well feasible. There is a lot of safety data which is available for robotic when it comes to robotic liver. As it comes for pancreatic urinectomy, it is, I think, in a way, little unique for other, as compared to other GI, because it's a complex resection and difficulty anastomosis at the end of it. So it's a time-consuming thing also, and each step is also to be done with care. So it is physically taxing also. So you need a team approach in the beginning at least. Once the technique is known and the duration of surgery is reduced, then yes, possibly single surgeon is fine to do it. But otherwise, in the beginning, you need 2 teams, and with that also, there is no strong evidence which has suggested superiority or benefit. So I think pancreatic urinectomy is still far away from getting into routine clinical practice or recommendation. As it is for liver resections, yes, of course.
Raju sir, and when it comes to robotic thyroidectomy, what evidence do we have till now, but how it fares with open thyroidectomies?
So in terms of outcome, robotic thyroidectomy results are like equivalent to open thyroidectomy. But as such, if you see, that is not better than open surgery. So only benefit of robotic thyroidectomy is possible. Otherwise, that is all equivalent to open thyroidectomy.
So standard of care still remains open thyroidectomy, and this is
yes. So especially for young females who wants to avoid scar in the neck, that is good for robotic is good for them.
It's a subset of our patients.
Yeah. So here also you have to select your cases very carefully, because if size or like quite extensive like involvement is surrounding structure involvement is there, in that case you may have to convert to open. So case selection is very, very important, and patients should be motivated to avoid a scar, and that's why they will undergo robotic therapy.
Thanks. So now if we are done with the evidence, if we can now speak about your own practice. All of you have been excellent laparoscopic surgeons and in head neck open surgeons. With the advent of robotic surgery, how has your practice changed in terms of MIS? In terms of, are you more boldly taking certain patients up, which would have been difficult in lab?
Okay, right. I think obviously, as you said, the advantage is there. If you find a challenging patient, then you can do with the robot, that is very good. But the technology is so good, you can use it to explore it. Okay, like you wanted to go to the moon or something. So I think for what other you're doing laparoscope, if you're doing something new like extension, you could explore anatomy, like you showed in the video, and that is a really good thing. It will take a bit longer time, but it can form. It will give you a roadmap of the golden laparoscope, and then you can make it shorter. So I think for complex procedures, it will be good. For difficult, technically challenging procedures, if you want to explore and make the work of it, is a great one.
If you ask for the change in practice and maybe answer in how we have evolved, I started open surgeries. From that I learned that I didn't have robot there. So I started doing open prostates, open cystectomies, open fascia and all those. Later on when I transformed to robotic surgery, now I feel I am more confident surgeon possible. The things which were not that greatly visible, not greatly, easily doable, are now easily doable. Second thing, I feel I can pass my expertise to the next generation or maybe my fellow surgeons in a better way compared to open surgery. If I talk about the pelvic surgeries, definitely my life is much easier now. If I talk about partial nephrectomies, like partial nephrectomy is one kind of surgery where we are kind of scared all the time because maybe we may cause Boston margins and urinary leak and all those things. And ischemia time, cold and warm, very kind of. With this robotic things coming and we're getting more experience and more expertise there, and now we're confident doing any sort of partial nephrectomies without bothering about this ischemia time, without bothering about this margins, and without bothering about the leaks and this bleeding, because most of things are now so nicely visible, so nicely resectable and can be repaired so nicely that my confidence level is gone.
And the magnification of the dexterity itself adds to that.
Right, so it's kind of practice changing for me. For maybe little masters where I used to have done a practical surgery, now I can do partial nephrectomy.
The very fact that we only go
as Conclave sir and Abhay said, it is we can explore more, which we cannot do in laparoscopy. That is for sure, because there is a different sense of control and the fineness or meticulousness in this section. So some of the cases which we have done in Tata or pancreas, I don't think we would have ever done them laparoscopically, which are certainly which are locally slightly advanced major vessels. All that is definitely much better possible with robotic surgery. Of course, there is a learning curve. We have to negotiate that first. And once that is done, then yes, head to head, there is certain advantage of robotic as compared to laparoscopy in specific situations. So you can choose that better with available.
Pertaining to thoracic surgery, because if we are talking about how, because that is again in the pelvis and the thoracic cavity are two places where the exposure makes a lot of difference to the surgeon's life, where the magnification which robotic surgery gives does help us a lot. So how do you think it has helped you from VATS to robotic?
Actually, I was fortunate to have a very high volume lung work and esophagus work. And when you do high volume of a focused procedure, numbers when you increase, be it pancreas or be it even rectum, you already know that 10% of that procedure is the most difficult. For example, lobectomy, for example, if you're doing a lobectomy, it's very fast when you're doing VATS. For your job is done. But when you have to do a sleeve resection, when you have to cut an anastomose, so I used to do it VATS, but then I found, how about we shift those cases to robotic? So today, after tasting the robotic technology, I don't want to go back to VATS because it is so easy to anastomose bronchus to bronchus, artery to artery, so comfortable. So in my practice, what I've done is, if the patient can afford, if it is a sleeve, a complex section like sleeve, they go for robotic. If it's a right lower lobectomy, I don't even convince the patient I do VATS. Right upper lobectomy, left upper lobectomy, I convince the patient for robotic. Mind you, when I started lung, for the first 50 cases, robotic stapling was not available in India. And for every, I used to mobilize, and the stapler I used to put glove, wash them again. For each artery, I didn't have an assistant, I had to come and staple, then go back to the console and do this. I was begging them, please give me staples. But once the stapler came, it became so independent that if the patient is affordable now, I say just get on with the robotic because it makes your life very easy.
Yeah, there was two specific points which I wanted to was one was the use of like the ICG immunofluorescence and the use of staplers, how that has slowly helped us in the surgeries. So to question to all of you individually, which surgery, I think part of it you already answered. Given today, which surgery would you rather do robotic? Like, is it depending on the organ or is it depending on case-to-case basis? You decide on that. As Saraj has said about sleeve resections, that is somewhere where definitely then.
Coming to my specialty, case selection is important. Most important is the affordability. It should be affordable. It's technology that costs money. There's no doubt about it. But cost is not that important factor nowadays, Because if you compare the cost of this open surgeries and this robotic surgeries, there's hardly maybe 20% difference in cost, and the people are used to it.
So say this is an ideal world where you have everything, patient is willing, and your funds, everything is, that's not a problem. You just have cases. Based on that, how would you choose? Like whether this is, like someone has said already, like a simple lobectomy, probably a vaccine will be much easier and faster one. Go there with that. But a sleeve, again. So similarly, in your case, it will be maybe a partial, which was a borderline partial, okay.
So in my practice, I will do all the prostate by robot. I will do all the partial by robot. And bladder, depending, because I don't see much of advantage there. But if the patient is willing, I will do by robot, otherwise open is good enough for me.
On the other end of it, which are the surgeries which you would not do robotic? We'll talk about we'll take the first question first about the wrong.
Yeah, patient is fit for anesthesia, fit for position, fit for pneumoperitoneum, then I don't think that there is a contradiction. But if there is any contradiction for anesthesia or maybe positioning, because when you do processes, the patient is the deep head low position for a long period of time. So the patient is having some problems like when the raised intracranial pressure is a issue, like glaucoma patient and all those, then we have avoid this surgeries. Or bad done, and we can say that pneumoperitoneum is not good for the patient, and we can avoid it.
Basically, it's a really unfit patient for who cannot withstand a pneumoperitoneum and robotic. Okay. Are there any wrong organs right now with the evidence which we have where we would be more cautious in using robotic?
I think because the gynae person is not here. First thing is CS cervix. I think it's very difficult now to convince a patient to do a radical hysterectomy for a patient who is a cervical cancer. It's very difficult. The minute you say minimal access, next visit when they come for the second consultation, sir, how can you do this to me? All these things come up. It's very difficult to convince. Endometrioms are very easy to convince. The all they do so many endometrioms per week. But cervical cancer, the verdict is so strong that the public has decided we should never do for cervix. I think in the ideal world, I went to a hospital where there were 9 robots in one hospital. They were doing gallbladder with a robot. Absolutely, I thought it was a waste of resources, waste of money, etc. You can do any surgery with robotics, but anything that you should not do minimal access, you should never do with robots. In my case, the same thing applies. Tumor more than 6 to 7 centimeters in size. I would not do VATS, I would not do robotic because I'm going to make a bigger incision to take it out. So why waste time? Second thing, if you are going to spill the tumor inside while doing dissection, or the patient is already having peritoneal disease in the esophagus, I don't think we should not actually use a robotic for that kind of thing. Anything which is against MIS, I think we should never do. I had a problem with obesity, sir. So we have an X system. When you do the pelvic part, it is fantastic. But the minute you go upstairs, it's pathetic. So I just throw the robot away and do it lab. Similarly for the pancreas, the resection part is so easy to do by lab. You do it for the robotic, for the suturing you can do. So I think
hybrid.
Yeah, hybrid has a big case.
I think it is a concept of relativity. It depends on how you master it. So cervicals came and said okay because there's a luminous related now, but then there are people like Deepak Chain and that they will say to the cervix really good margin and really good. For us, I think even I would say not thing. But posterior acceleration because cervix is okay, we say direct combined and then stay to the cervix there. Posterior acceleration you had an interluminary disease there. So if it's just that they're not connected to the luminary, it's okay. For posterior acceleration you can't find a way to direct combined and stable. Those ones you definitely do not happen. In fact, you'll be surprised that in our example, take on cytoreductive surgery for ovary for MIS and they should work. But you won't believe it, 25% of CRS in US is done with robotic approach. It is unbelievable. The outcomes have been compared, they're not different. So, because the outcomes of ovary are bad, whatever you can do, so it is still the same. But
Even there, the mirror study is going on right now, which they might be doing with the RCT. There is also nobody. So yeah, the two studies which basically rock the gynecological world with CS cervix and it almost completely stopped. So now is there any role of MIS for cervical cancer at present? So since
the trial going on, I think the other opposite of laminate, so when the trial comes out, that is okay. But individual centers, I will have shown they are okay. But it all depends on
So they came up with these, okay, now low pulse-twin, do stapling. Yeah, so like transanal, when they had a...
Same thing for TAT, even for the rectal cancer trial, when Microsoft and Alacata had come out, they say it is not oncologically not
in our country actually people, at least outside academic institutions, they are coming asking, they seek robotic surgery. And for cervical cancer, at least we have found that they are not seeking robotic surgery for whatever reasons. They are not seeking it. For endometrium, they are seeking. Lung, they are seeking. For pancreas, they ask, sir, can you do robotic pancreas? They never ask for cervix. So it's a little difficult to.
So yes, you already telling about the other controversy which came up over after the roller RCT came up. And yeah, that was in 2019, but since then we have the real also which has come out last year from China, and that shows it is actually better. It is not exactly how the roller RCT showed. So for the times ahead, what do you say regarding now coming to the training part? As all of you said, what is important is the learning curve. To negotiate around the learning curve, that is very important because otherwise it can be dangerous to learn and understand. So what would you say about the options of training is available? And the next big thing is after individual surgeon individually gets trained, even to get a complete robotic program going in an individual hospital, because that is not a one-person job; it's a complete team who has to be trained. So how do you give us some insights on that for with the present resources which are available in the country? Obviously, the long-term oncology data will have to wait.
I think that training part is little unfortunate. We don't have a formal structured training program which is established even for laparoscopy in our country and also for robotic. Very few places where you can actually dedicated have programs and fellowship. Plus in oncology, as it comes, is that it has become more and more system and specific organs. It is difficult to learn everything at one go. Colorectal, yes, becomes more specific and good volumes are also available, so the training program can be established better. But for the other surgeries which are not so, even for urology, it is much better. But for the other surgeries, for example, thoracic cancer or for the HPV, the surgeries themselves are not so commonly done at centers of experience. It is difficult to have programs also running established to transfer these surgeries for training. So at present, I think most people what they do is have some short course of training somewhere else out of the country, identify a place, get 3 months or 6 months of dedicated work, observation of that work and come back. But that is over and above what you have learned already in basic open oncology surgery.
I think the first problem is that surgeons are forced to choose. So when you go for training, the training is site specific. Imagine I was a surgical oncologist. They asked me, sir, you can't say surgical oncology, you tell me HPV or whatever. Then I said lung, because see, as a hospital, to start a robotic program, you need focus to high volume of one procedure, like in TMH. They have high volumes, they can select cases and then build a program, right? So in my situation, it was lung. I had high volume, and immediately my thing was lung. I will ask the company, okay, I want training in lung. They said, India mein koi doctor hai nahi. So I said, what to do? Sir, we will train you in colorectal surgery. Fir aap lung kar do, koi baat nahi. So today, fortunately, we finished 150 plus lungs now. So I'm a proctor for lung anyways now. The situation is like that. First thing, you're forced to choose. So the surgeon has to go prepared, and I have to choose a particular specialty. And now most hospitals like yours, you are now site specific and you are choosing. Second thing, when you set up a program, I think you should focus on getting volumes and selecting cases. I have seen many places where the first case, they start with a sleeve lobectomy. So they are going to fail. They do that one case, 24 hours they do the case, and next day hospital says, boss, robotic mat karo. You will stick to prostate and bladder. So I think we should start small. We should start from easy and slowly step up.
I think most important thing is productivity. Productivity for the hospital and productivity for the surgeon. Today I employ 2 surgeons, okay, and operate 100 cases. Today you see you want to multiply and take 4 surgeons, you still operate 100 patients. So you are at a loss. So there should be growth and the case per surgeon should be the same. So if I train 20 surgeons, the volume has to multiply by 20 times. If you have enough volume, then your robots have to multiply 25 times. Otherwise it becomes like TMS. Okay, 1 robot, 4 surgeons, it becomes 30 surgeons. So de-scaling can happen. So I would ask Medica to please donate a robot to us.
Sure, I'd like to add here. See, robotic training, I mean, first you train the surgery, robotic is just a platform of doing a surgery. Like, you first have to teach the surgeon how to do the surgery, you open or whatever, and then transform into the robotic platform, just how to use the technology for the surgery, right? And
Yeah, first be a good surgeon, then you can be a good robotic surgeon.
Right. And so that's unfortunately happening now that we're getting our surgeons who are trained in robotic surgery, but they don't know how to do open surgeries.
I was just talking, our urologist, the minute he sits in the robot, fantastic. For open surgeries, sir, please help us improve. So it's turning.
Right, and fortunately in urology there are structured training program for robotic training as well. So some are sponsored by the Robotic Foundation itself. So we have a structured 1-year fellowship for robotic, and that's the urology training. And coming to the second question, setting up a robotic program, because working in a corporate hospital and having experience of seeing 2 robotic programs in a very short time, spend time, solid experience. You have to add value to the organization, or maybe see some economic sense to the organization, right? And at a certain one time, you see that the surgery is going, the hospital is going, and it's adding value and not causing any loss or revenue loss to the hospital. So if you have this enough volume of cases, then only should be starting robotic, not like starting robotic and just for the volume. Like we did, maybe we think that we are a successful model. So like we had first the volume and then we got robot and then we started the program. And it has to be a multidisciplinary program, not a single specialty kind of robot program. Area, right? And as I said, adding the number of surgeons is not going to be the solution, right? I'll just quote, recently in Medica got this robot, at the same time the CMC got the robot, at the same time frame. And at the end of year, CMC had 12 trained robotic surgeons, and in Medica we had 4 trained robotic surgeons, and we had done the same number of cases. That's it. Thanks.
So yeah, that goes for our training as well. Like that's very important. Otherwise, even our robot is of no use. So yeah, as we discussed about that, certification courses and also, like you said, for thyroid, robotic thyroid, whether there are any courses available or and because there's so many approaches to it, and every surgeon's way of approaching the thyroid is different in most cases, as we see. So if you can enlighten us on that in our setup, that would be great.
In India, I don't think any robotic thyroidectomy program is there. And most of head and neck surgeons who have learned robotic, mostly they have gone outside, spent some time, maybe a few weeks or a few months, and they came back and then started doing with some mentorship intuitive. So gradually everyone has learned, but situation is improving day by day. And if you take 5 years back, like hardly few centers were doing robotic, but now even like Calcutta, now I think 5 or 6 robots are there in Calcutta. So number of cases, robotic cases are improving, and each specialty is doing, increasing their number. So gradually learning that training will come. So head and neck, if you see like Delhi, Dr. Abbas is there, he is doing very good number. Like head and neck, if you say robotic head and neck, he is doing very good number. Like maybe more than any other center, at par with any other center in the world. So, and now he has some fellowship program. So each center who has a good case load, they have some training program, maybe 6 months or
1 year. So those who will come out of these programs, they will definitely start set up a robotic program in their center, wherever they join. So gradually that is improving, but still that lot of things have to be done to improve robotic training, especially head and neck. That will take a lot of time because head and neck only like transoral robotic for pharyngeal cancer, that is like non-established. But thyroid and all, a lot of controversies are there. The philosophy is totally different. So that will take time, but gradually, because this is a new technology and that is going to improve in future. So today or tomorrow, everyone has to accept that this technology will stay here. That is not going to go.
So we are too fortunate than you because of the time lag that we have. All of you to guide us through when we need, which was probably not the case when you started off. So coming to the future of robotic surgery, the big question that in the room is regarding the cost of treatment. The one point where many times the decision needs to be made whether we can go ahead with robotic or not. How do we see that in the near future? Since it has been more than 20 years now that Intuitive brought their robotic system, and as you see, we are seeing newer platforms coming by every day, including one in our own country.
I think at present you should say it's value for money or something. I think the cost is still the same. I think much has changed. For others which you take at lower price, you have to compromise on quality. I think they don't want to do specifically on that. If you want to go for excellence, you pay for it. It's like having a car, take it from A to B, but if you want to reach your destination, sometimes you have to pay the price for it and go to Sarvanac and a very expensive operation.
So, when there is competition, obviously price also will come down. So, I remember going with Saklani sir we were really planning to buy the CMR robot. We went and I saw, the minute I used it for half an hour, I realized this is not for me. I can't do whatever I am doing with this kind of a thing. So, I'm not against it. But one day will come when there will be a lot of systems. Today, many of these companies keep the machine with you and tell you just pay per patient and not invest in the capital cost. If some form of pricing comes into the picture, I think there will be more penetration. So the big companies also are looking at some models where if there's a need and somebody wants to do robotic surgery, then the capital cost is not the hindering factor. So everybody wants. Today, anybody who walks out of TMH or Adyar or Rajiv Gandhi, they want to become a robotic surgeon. Today, the need is there. Every conference where you want to speak, 10 people come and ask, I want to get trained. So there is this need that I have to get trained in robotic, otherwise future Achanayo. So just last month, 2 robots, Mantra, SSA Mantra, were installed just 200 kilometers from our place. So they decided that they are going to do gallbladder, they are going to do esophagus, thymus, small procedures with robotic. There is a marketing tool that if I don't have a robot, I cannot stay in society. It's this situation. So if you find a place like that, join there. If you don't, then I think competition slowly is coming. You will see some company coming up with better robots also.
Yeah, the demand is increasing, So now surgeons want to be robotic surgeons. Now the patients want robotic surgery, like gallbladder, So I feel more than the patients, more than the surgeon, the patient is pushing, sir, I want robotic surgery, So that's one thing. And second, this market is growing. Market is growing because even Make in India Mantra is coming. And so as the competition grows, the prices are going to come down. And significantly, we have seen the prices is one-time investment for this the machine, and then this consumable cost, like printed cartridge models. So if you can cut the cost of cartridges, that the consumables, then maybe your overall robotic program cost can go down significantly. And in that matter, maybe the innovators are also in maybe some pressure to reduce the cost of consumables, so that now they are indirectly increasing the number of uses. So earlier the sequence which can be used for 10 maybe now can be used for 15 times. So then indirectly they reduce the cost of the consumables. And there are various models like even the Da Vinci is now offering pay-per-use models. You don't need to buy a robot now. They will place robot, the path robot for you, and you pay per uses. So this is the future. Maybe it's going to be widespread. More surgeons, more people having more hospitals having more maybe tier 2 dialysis having robot surgeons.
So coming to the last part regarding innovation and research. So there are other exciting parts like single port robotic surgery, which is not yet that popular within our country, but that shows.
I think you have to travel to see. I would have thought it would have never become a successful model. Then you go to US or meeting and you see there and you speak to the labs and you find out 30% of the hysterectomies in Korea are done with single port robotic surgery. Then one of our fellows goes to Cleveland and you see we are already all the advanced executives for screening program early cancers. So in a single list, every government has a list of 5 single port robotic panels and one large in one time. So it is going to happen. I think we are concentrating on advanced cases. Once you go on screening with early cancer, then this will be there. For head and neck, I think obviously single port is the thing to do. Even for people like John Marks and George, we single port robotic cancer and there is a big market. In fact, EFTM has to be moved for single port, even in the stuff.
Definitely that this has made a mark for especially for transoral robotic surgery as well as even thyroid. Just only like small incision size becomes smaller. Just only one single incision you can do full procedure. So in Korea, like a lot of centers are using single port. But here in India, still cost factor is coming for use of single port. So I think in India, still I don't think any single port system.
So the price of single port to buy is 5 million. And I think the camera comes for only 7 to 10 uses. And the camera costs $75,000. Right now, that is the US pricing. So if money is a constraint, I think it will be a big problem. I think big institutions like AMH, I think they should be the ones who start, try, test. Definitely, surgical wise, you can do a lot with single port. There are a lot of indications. It is the price which is the hindrance. Somebody will find a way. Either AMH finds or somebody will find a way.
Please donate generously.
So, particular question to Manish sir, about robotic radical cholecystectomy trial. Like we know, like if there has to be any, there are case report case series now which still exist, very small numbers. But if it has to come, I think it should be our country because we after all see the maximum burden of CHUV. So, do you think is it time like maybe DMS and high volume, obviously it has to be from high volume centers if we are ready to run a trial of this sort?
For radical cholecystectomy robotic, not much data again. In DMH it has been done, but not in those many volumes as yet, but selected cases, early cases, that is good because one of the problems with radical cholecystectomy particularly is the way you handle the gallbladder. It's not like the organ per se is not so tough or rigid. It's quite, and you cannot allow any kind of a perforation or a spillage because that is completely changing what you are doing the surgery for. So that becomes a little bit of a problem. Sometimes you have a distended, dilated gallbladder, and to maneuver it with that robotic haptic this thing can be a challenge. So that is when only early cases have been chosen, whatever have been chosen. Apart from Tata doing some robotic gallbladders, I think Dr. Anil Agarwal from North, he has done a lot of laparoscopic surgeries for gallbladder. And yes, you are right in that sense that India or this part is having highest incidence and some of the data which can be generated will be from us. So something like this can be thought of and possible
with the right patient selection.
With the right patient selection.
Okay, thank you so much, sir.
Sarina for a very insightful meeting, and we wish you best for your robotic program. Thank you.
This is the last session, so we'll felicitate everyone while we are on stage. There's a small change in program. The program of recent advances in radioisotope therapy, integration in personalized and precision oncology by Dr. Vikram Tere was supposed to happen in the other hall, but that's running late. So we conducted it here. So we request everybody to please stay. So Dr. Vikram does not need any introduction. He's the director of Department of Nuclear Medicine and PET scan at Jasdok Hospital, Mumbai. Thank you so much, sir. Somebody.
Oncology. Sir, please.
Thank you, Dr. Adil, and invitation for coming and delivering this talk. Nuclear medicine has been around for several years now, more than 50 to 60 years, and we have entered the realm of therapy for a long time. And this slide sort of summarizes what we have to offer in the field of therapy.
all of you know, we can treat Graves' disease with radioactive iodine. We treat thyroid cancer, again with radioactive iodine. We are very effective in the therapy of skeletal metastasis using isotopes like strontium and samarium. We can inject painful joints and give significant pain relief. Recently, we have entered in a very large way in the therapy of two major class of diseases. One is the therapy of neuroendocrine tumors with the help of lutetium dotatate, and therapy of metastatic refractory prostate cancer with the help of lutetium PSMA. We have also been treating hepatomas and hepatic metastasis with intra-arterial therapy with TheraSpheres. What I will be focusing on today is the field of theranostics, where we use a pair of isotopes and a single compound to diagnose a disease and to treat it. So we have now three very powerful pairs of compounds with which we treat these three classes of tumors I spoke about. We have gallium-68 gallium, which is a PET isotope. We label it with dotatate, dotatop, or dotanoc. These are compounds which image somatostatin receptors, of which there are several types. These isotopes image mainly the somatostatin type 2 receptors, which are expressed intensely on neuroendocrine tumors. And we can then, after imaging them with gallium, we can take away gallium and bring in lutetium and label it with the dotatate. Lutetium is a beta emitter and it's a lethal isotope. It will go and destroy whichever lesions have been picked up on the gallium imaging. So we have a combination of gallium dotatate for imaging and lutetium dotatate for therapy. We also have actinium dotatate, which is an alpha emitter and which can destroy with great intensity the metastatic lesions which are picked up on the gallium dotatate. The other pair is gallium PSMA, with which we can diagnose metastatic prostate cancer, and once we have diagnosed it, we can treat it with lutetium or actinium PSMA, another diagnostic pair. And a third pair, which has come up recently, is FAPI, fibroblast activation protein inhibitor. As you know, the tumor consists of tumor cells and it consists of the tumor stroma. The tumor stroma can now be imaged with the help of FAPI because the tumor stroma has fibroblasts. And in cancer, these fibroblasts get activated and they start expressing the fibroblast activation protein, which we can image this protein with the help of gallium FAPI. And then once we can image it, we can treat with lutetium FAPI. So these are the three theranostic pairs which we have available for treating. The gallium FAPI and lutetium FAPI pair has a potential of treating almost all cancers, because almost all cancers have stroma and the stroma express fibroblasts. So every cancer which has stroma can be theoretically imaged with gallium FAPI and can be treated. And this is a very rapidly growing field, and I think in the next 5 years, the treatment with this theranostic pair is going to play a very major role in the treatment of many cancers which are not responding to our regular chemotherapy and the radiotherapy regimes. While gallium dotatate and lutetium dotatate is specific for neuroendocrine, gallium PSMA is for prostate, FAPI is a pan-cancer diagnosis and treatment agent. We will be talking about this, how precision medicine and precision therapy we are doing. When we image a patient who's got neuroendocrine tumor, we get various patterns. What you can see here is a patient having somatostatin receptor avid disease. And we can see there are a lot of lesions here. And when the lesions start expressing this somatostatin more than the liver or more than the spleen, these are the patients who are eligible for therapy with lutetium dotatate. So we grade this patient uptake when what is known as a Krenning score. When the uptake is less than the liver or equal to the liver, these patients are not really candidates for lutetium dotatate therapy. When the uptake goes more than the liver or even more than the spleen, then these patients are ideal candidates and they respond very well to lutetium therapy. One more thing we have realized, that there is tremendous heterogeneity in the tumor in the body. All the tumor metastatic sites don't behave the same. Some of them express somatostatin receptors, and as they become more aggressive, they stop expressing somatostatin receptors. So now they start becoming more and more hungry, more and more aggressive, then they start picking up FDG, fluorodeoxyglucose, which all of you have heard of. So nowadays, it is a routine in neuroendocrine tumors to image them both with gallium dotatate and with fluorodeoxyglucose, FDG PET. And we combine these two and we find, so far, as you know, neuroendocrine tumors are classified as G1, G2, G3. G3 tumors are the more aggressive ones, which have to be treated with chemotherapy. G1 tumors are the most differentiated ones, which are very suitable for lutetium dotatate therapy. So when we combine gallium dotatate and FDG in the patient, you can see here is the patient who's been imaged with gallium. You can see extensive metastatic disease, studded with metastasis in the bone, in the liver. The same patient with the FDG scan shows absolutely no uptake in most of these lesions. So this is a combination of very avid somatostatin disease with no metabolically active disease. Such a patient will respond very nicely to lutetium dotatate therapy. This is a G1 tumor. As the patient goes to a G2 tumor, which is more and more aggressive, you can see now that the FDG scan starts becoming positive. These hepatic lesions which are hot on the gallium scan are also hot on the FDG scan, and you are seeing a lot of marrow uptake also. So you are now finding concordantly hot FDG uptake and gallium uptake on a more advanced, more aggressive tumor. Now these patients will do well with lutetium therapy, with lutetium dotatate therapy, but you also need to add capecitabine temozolomide therapy to them, which will take care of the aggressive component of this neuroendocrine cancer which we are dealing with. And finally, the grade 3 tumor patients, on histopathology they are grade 3, you can see their uptake of FDG is very intense in them. So far we have been taught that G3 tumors you cannot treat with lutetium dotatate therapy, but you can see in this so-called G3 tumor, which is picked up on a biopsy, is showing intense uptake of lutetium gallium dotatate. So we can also treat such tumors with lutetium, but it has to be again combined with an additional chemotherapy. So if we go just by the biopsy, you will say this tumor is G3, you are going to straight give this patient chemotherapy, but now when you combine the imaging, you can tailor the therapy to the particular patient with great precision. So this patient will require both lutetium therapy as well as chemotherapy. That is the beauty and the strength of our nuclear medicine imaging. So here is what happens. Here is a patient with extensive skeletal metastasis, which is very strongly positive on a gallium scan. You can see all the bones are studded. Now this patient was treated with all sorts of chemotherapy because his FDG scan did not show any uptake, but still it was supposed to be a G2 to G3 tumor, and he was given all sorts of therapy and he did not respond. But look at the amount of intense gallium uptake in all these lesions. When we started, finally they sent to us for lutetium PRRT, though the lesion showed G3 disease. And you can see after giving PRRT, there was a very significant response. Almost all the lesions have gone. So this is how we tailor. We just don't go by one biopsy which says this is a G3 tumor, only chemotherapy will work. We will image this patient with both gallium dotatate and FDG and tailor the therapy for him particularly. This patient required both chemo as well as the lutetium therapy, and he got an excellent response. Then the same is what we use for prostate cancer. We use gallium PSMA to diagnose and to map the extent of all the metastatic lesions which are avidly picking up they're expressing PSMA, so we can image them with gallium PSMA. But we also now combine every patient with a FDG scan. So we do a gallium PSMA scan and we do an FDG scan in the same patient to see what is the biological character of this tumor. All the tumor cells which are very aggressive will pick up FDG. All the tumor cells which are only expressing PSMA and not very aggressive will express only PSMA and will be hot on a PSMA scan. So here we have a patient who is a 68-year-old, recently diagnosed with Gleason 7, PSA of 1255. You can see there is intense uptake of PSMA in all these multiple lesions. He's got skeletal metastasis in the skull, in most of his vertebrae, in the pelvis. He's also got a lot of lymph node metastasis. But when we do a FDG scan, you can see that very few of these lesions are picking up FDG faintly, some of these lymph nodes. So this is a predominantly PSMA avid disease. So he will respond very well to lutetium PSMA. As opposed to that, we have a patient who's again got Gleason's 4+5, rising PSA, extensive PSMA uptake. All these skeletal lesions are showing a lot of uptake on PSMA. They are also showing a lot of uptake on FDG. So it is a concordant uptake on FDG. So it is a mixture of cells which are aggressive and cells which are expressing also PSMA. Such a patient is unlikely to respond solely to your lutetium PSMA therapy. He will require a combination of lutetium PSMA along with a low dose docetaxel therapy. And you are finally seeing here a 60-year-old patient, Gleason's 9. You can see on a PSMA scan, the prostate is not picking up much of PSMA. But on a FDG scan, there is an intense uptake in the prostate of FDG. So this is a discordant lesion, and this patient is not likely to respond to lutetium PSMA. This patient will respond better to a chemotherapy. So for precision nuclear therapy, we are characterizing every patient individually by doing a combination of gallium DOTA or gallium PSMA along with FDG. And we characterize the disease perfectly and give the appropriate therapy with the best results. So here you have a pre-PSMA gallium showing extensive disease, and after giving at least 3 to 4 cycles of gallium PSMA, you can see there is an excellent response. But prostate cancer is a very funny cancer. As time goes by, it is an incurable disease, unfortunately, because it changes its character. And as you treat the castrate-resistant prostate cancer, it changes its plasticity, as we call it. It can undergo neuroendocrine differentiation. And how do we pick that up? You can see here is a patient whose PSA was very high. He was given the appropriate androgen deprivation therapy, the docetaxel therapy. The PSA fell, but the lesions became more and more. That was a clue that in spite of the PSA falling, the patient was clinically worsening. That was a clue that he is becoming undifferentiated. So when we did the DOTA scan, which shows neuroendocrine differentiation, you can see there was an extensive uptake of gallium DOTA in all these lesions. That means these lesions had become neuroendocrine tumors now, expressing somatostatin, and it had undergone a de-differentiation. And when we also did a FDG scan, they were also showing intense metabolically activity. So the change in character of the patient's disease as time goes by, where the PSA starts falling, the PSMA expression starts falling, in spite of the patient become clinically worse. That is the clue that a neuroendocrine or de-differentiation has occurred, and we confirm it by using alternative imaging agents like gallium DOTA and FDG and give the appropriate therapy for this patient. So here was a 53-year-old male diagnosed with a well-differentiated NET of the prostate, right in the beginning only. And the histopath was a prostate mass with well-differentiated NET, MIB index less than 20. PSA was very low, as is the situation in a neuroendocrine differentiation. When we did a DOTA PET scan, you could see that there is a huge mass there. You can see this mass which is intensely active on a DOTA study. When we did the FDG PET, there was not much activity in this mass on a FDG. So we started treating this patient with gallium, with lutetium dotatate. And as we treated it, you can see that after the first cycle, and the second cycle, and the third cycle, there has been a progressive decrease in the uptake and the size of the mass which is there. So we plan to give this patient at least 6 cycles of lutetium dotatate therapy. It's a rare case of a neuroendocrine right in the beginning differentiation. Usually neuroendocrine differentiation occurs at a later stage after the cancer changes its character after androgen deprivation therapy and after giving docetaxel and everything else. But here, right from the beginning, it was a neuroendocrine differentiation and the patient had severe pain in the gluteal region because there was a locally infiltrative mass. And after 3 cycles, he is doing quite well. His pain has gone down and he is symptomatically much better. Now we come to the pan-disease uptake with FAPI. As I told you, fibroblast activation protein inhibitor of FAPI is a new kid on the block. We can diagnose almost any tumor. Every tumor has stroma, every tumor expresses tumor-associated fibroblast. We can image them with gallium FAPI. Here was a 41-year-old female who had recurrent left parasagittal hemangiopericystoma. This is a fairly rare tumor which affects the skull, and this patient had extensive metastasis all over the body. She had lower limb weakness, urinary symptoms, she was unable to walk. You can see that we have done a DOTA scan. The hemangiopericystoma express somatostatin receptors. So when we did the DOTA scan, we could see these metastatic lesions were showing uptake. On the DOTA scan, you can see in the lung lesions were there were liver lesions, and there was a mass in the sacrum. Now, there is no therapy for this hemangiopericystoma. No chemotherapy works. So here was this lady who was bedridden because of the sacral invasion. Then we did a FAPI scan on her, gallium FAPI. And you can see on a FAPI scan, intense uptake. You can see here on the right side, all these metastatic lesions were expressing the fibroblast activation protein intensely. Look at the sacral mass, very hot on the FAPI. You can see the liver lesions, very hot on FAPI. Then we sent her for lutetium FAPI therapy. And after 2 cycles of lutetium FAPI therapy, you can see this sacral lesion which was huge, which was causing her to be bedridden in severe pain and with weakness in the lower limbs, showed dramatic reduction in the uptake. So the lutetium FAPI caused tremendous reduction in the uptake and the mass became less, and the liver lesions also showed a less dramatic reduction, but a reduction in the size was there. But the functional improvement was phenomenal. Here was a bedridden female who was urinary incontinent, started walking, she's back to teaching in school. So from a patient who had absolutely no therapy available to her, no chemotherapy works, we were able to make her functional. It's incurable. There is no way we can destroy all the lesions, but we have made her functionally active. And as we go by, we are probably going to give more and more therapy till she tolerates it well and give her a good functional quality of life for several years. So that is the importance of this lutetium FAPI. This is the last slide to show you how we can tailor as the precision medical oncology for every patient and give significant relief. Thank you for your attention.
Thank you so much, sir, for the very enlightening and interesting talk. I would like to invite Dr. R.B. Asoka, sir, for felicitating Dr. Vikram Reddy, sir. And I would also like to advise Dr. Saurabh Datta to felicitate Dr. R.B. Asoka, sir. Please, everyone, please be on that for the first. Thank you. Thank you so much everyone for your patient listening as we conclude this Medica Cancer Conclave 2023. Hope to see you soon next year. Thank you so much everyone for joining. Thank you.
खत्म हो गया ये